dear friend, a very, very dynamic leader on the scene of diabetes, especially in India and abroad, somebody who's very much involved in type 1 diabetes. She's consultant diabetologist and director at Rudraksha Institute of Medical Sciences and HOD Clinical Research at RIMS Ahmedabad. Very active in ISPAD, very active in type 1 diabetes as
Recording
well as all
in
the
progress.
things. So with that, welcome to me, and I would like you to kickstart the Diabetes and Women Symposium.
Thank you so much, ma'am, and congratulations. Our first day of CMRE is rocking, and we have the first session at the JS Bajaj Hall right now, the Women in Diabetes. And we've got such eminent faculties, and I'm so excited to introduce our first speaker, Dr. Lily Rodriguez, ma'am. Lily, ma'am, actually is one of the most deserving people to start this session because we've just attended her very successful EVA stride at Hyderabad. She is a consultant physician and diabetologist and currently the director at Stride Hospitals at Hyderabad. She's the chair for the Telangana RSSDI and the scientific chair for Telangana RSSDI Conference of 2023. She's a task force member for Women and Diabetes Center for the Central RSSDI. She's the founder for the EVA Stride Conference, which all of us were so happy to be a part of. And she's a principal investigator for several global and national research trials. With that, over to Lily ma'am for her deliberation.
Thank you, Dhruvi, for that. Thank you. Thank you for that wonderful introduction, Dhruvi. So nice to have you also. Let me share the slide. Coming.
No, not yet, ma'am. Maybe you can unshare and share again.
Okay.
Yeah, just wait.
Yeah. At the outset, I would like to congratulate Shalini and Dr. Rajiv Chawla for this wonderful, nicely crafted 3 days session where we really enriched with so many apt topics, and every year we have something new to share and discuss and be rich with knowledge to take it into our practice. So the topic given to me today is cardiovascular disease risk in women with diabetes. I have just put this slide to show that is there a difference
between... Can you make it full screen, please?
Yeah, it is full screen.
No, it's not. It's not moving also. It's full screen. It's not full screen yet.
It's on the slide mode.
You have to do resume slideshow.
Resume slideshow.
Yes, but it is still not full screen. Set up slideshow. Yeah.
I think I have to make it more. Yes. Is it okay now?
No, not yet slideshow. Maybe you can go to from beginning.
On mine, it is showing full.
It's not full. Maybe you can just unshare and start sharing again. I think that'll be better. Yeah, now it is full screen.
Okay. So, I was just about to say that the difference between men and women, the way we see ourselves, as you can see here, man, even though he is obese and centrally obese, he looks at himself in the mirror to be a very thin and six-pack person. And a woman, she always exaggerates her defects and she looks differently, unlike the man. So are women more complicated than men? This slide may look very, very, is this still small? Is it full screen?
Yes, ma'am, it is full screen.
Okay. This, as you can see here, men has only one switch on and off button, but you can see several buttons in women, and this may look very, funny, but at the same time, a woman has many physiological cycles, as Shalini was just introducing, that a baby now going to become adolescent, and then, the woman similarly will go through different cycles, and all of these cycles have different health issues related to the cycles, and a woman goes through all these cycles from childhood, childhood and adolescence, and reproductive age, and pre-menopause, menopause, and post-menopause, and each of them has different buttons and different problems, and particularly the cardiovascular disease. So just to introduce, men and women with diabetes have excess CVD risk as compared to their non-diabetic counterparts. Convincing evidence is that diabetes, both type 1 and type 2, increases the risk of CVD to a greater extent in women than in men. And relative risk estimates for coronary heart disease morbidity and mortality in diabetic versus non-diabetic people are generally higher in women, ranging 2 to 5 in women, whereas it is in men, it is only 1 to 3. Now, this is a continuum of CV risk in type 2 diabetes, which is common to both, of course, both the genders. Insulin resistance leading to IGT, then ongoing hyperglycemia, giving rise to all these complications, and finally, disability and death. Now, let's look at the various risk factors that give rise to cardiometabolic disease. Overweight and obesity is known to all of us. Abnormal lipid metabolism, age, race, gender, and family history, of course, inflammation and hypercoagulability. And one second, this is not seen here. Smoking, physical inactivity, unhealthy eating. And then we have age, genetics, and insulin resistance. Of course, increased lipids, as I said, hypertension and hyperglycemia, all of them lead to cardiometabolic risk and giving rise to cardiovascular disease. So insulin resistance is the center point of all of these complications. So now, the obesity, we all know, is one of the most important factor, the risk factor, among all the multiple factors. And then there are multiple factors associated with obesity, which give rise to increased CV risk factors. So overnutrition, this is what happens. So insulin resistance, hypertension, dyslipidemia, hyperglycemia, hyperinsulinemia, inflammation, and impaired fibrinolysis. And ultimately giving rise to atherosclerosis, coronary arteries, carotid arteries, cerebral arteries, aorta, and peripheral arteries, not to forget. So we most often talk about coronary arteries, but, and hypercoagulability status affecting the entire body. And finally, cardiovascular disease, which is a clinical event which we see at the end. So are women more at risk? Women with diabetes have a high risk of cardiovascular disease. Cardiovascular risk factors are more common, more likely to cluster, or more severe in diabetic women than men. And this may be due to biological or behavioral factors, or both combined. So disparities in accessibility, quality, and possibly effectiveness of care further disadvantage the diabetic women. Now, this is a meta-analysis which looked at the diabetes as a risk factor for incident coronary heart disease in women compared with men. A systematic review and meta-analysis of 64 cohorts, including 8,58,000 individuals and 28,203 coronary events which happened during this study. And what was found was there were 40% greater risk of CVD in women. So there's another meta-analysis of 37 prospective studies from North America, Europe, and Asia Pacific cohort studies. Collaboration has concluded that the overall summary, relative risk for fatal coronary heart disease in people with diabetes compared with no diabetes, is significantly greater among women again, which is 3.5% as compared to 2.06 in men. So coming to the InterHeart study, a large case control study, more than 15,000 cases of acute myocardial infarction conducted in 52 countries worldwide, concluded that again, diabetes is a more significant coronary risk factor among women than it is among men. So you can see here that it was 4.3 overall MI, acute MI in women and 2.3 in men. So women with diabetes have poorer coronary heart disease outcomes than men, higher case fatality rate, and lower long-term survival after MI have been documented in diabetic women as compared to the diabetic men, and further contribute to the greater impact of diabetes on coronary heart disease risk in women. So this is another study which was published by the American Diabetes Association, which was studied, again compared coronary heart disease in women with the other risk factors or causes of death in women. And you can see the black women as compared to the whites were, whites were slightly less than the black. And the overall coronary heart disease was much more the highest cause of death as compared to strokes and all forms of cancers together. Now, why this difference in women? Let's look at the differences, gender differences in atherosclerosis. The plaque erosion, women suffer more plaque erosions as a cause of ACS, and men suffer more plaque explosions, rupture, as a cause of ACS. Oops. It's not moving. Now, women have smaller coronary arteries, and this can seriously affect symptoms from anything that reduces diameters, like stenosis and endothelial dysfunction, which is more common in the women's heart. Now, coming to the microvascular circulation, which is also very important, this is what is seen in the men. Obstruction of epicardial coronary arteries is most common cause of ACS in men. Whereas when it comes to women, this is what you see. Dysfunction of coronary microvessels that can be the cause of ACS in women and are not seen on the angiogram. So angiogram is here clearly seen, but in women it can be missed. So CAD usually develops differently in women. Men, you can see focal stenosis, as well as whereas in women it may be a diffuse atherosclerosis. Now, what about the warning symptoms? Are they different in men and women? Yes. Most common for both men and women, chest pain, discomfort, pressure, or squeezing is there. But women are more likely than men to experience atypical symptoms, which occurs about 1/3 in women. Upper body pain, arm, back, shoulder, neck, jaw, abdominal pain, like epigastric burning, nausea, vomiting, shortness of breath, and heart palpitations may be the only symptoms of acute myocardial infarction in women. So these are all the different symptoms that can appear either in combination or one alone. So which are not really classical symptoms of a myocardial infarction that are seen among the men. So now the less obstructive CAD in women undergoing angiography versus men. So this is, a graphical representation of women showing less numbers in the obstructive lesions when they had myocardial infarction as compared to men. So this is another study called Y study, where about 50% of women sent home with normal coronaries continue to experience the disabling symptoms, possibly due to coronary microvascular or macrovascular endothelial dysfunction. And 673 out of 936 enrolled in WISE had persistent chest pain post the procedure. So persistent chest pain with no obstructive disease is not a benign condition in women. And 2 times the number of CV events like myocardial infarction, stroke, CHF, and CV deaths than those without the persistent chest pain were observed. So then this is another study by the Swedish National Registry in 2020. A recent analysis indicated that diabetes associated hazard ratios for most cardiovascular disease outcomes, particularly coronary heart disease, stroke, and heart failure, are higher in diabetic women than in diabetic men. And MI generally occurs at an earlier age in women with diabetes, and the mortality rate is higher. So all the studies all over have shown that women are more prone for CVD, especially when they have diabetes. So we all know that there is underrepresentation of women in the cardiovascular, in fact, all the clinical trials, and this remains low compared to the disease prevalence and death rates. Preservatives knowledge of gaps which adversely impact women. So now, when the women are not represented in the clinical trials, the guidelines also may not be there enough to help women with cardiovascular disease. So coming to the specifically once again to the risk factors which are women-centric, obesity, which has more CAD risk is about 2 to 3 folds compared to women of normal weight. This was, studied in the nurses' health study. The diabetes, we all know, blocks estrogen protection in premenopausal period and increases the risk of CAD 5 times in sudden cardiac death 3 times more than the non-diabetic women. HDL below 58 milligrams correlates with the increased sudden cardiac deaths, and women are known to have less than this. Arterial hypertension, isolated systolic BP, especially more above 60 years of women, is more common. Psychological factors like depression and anxiety is more common. Smoking history of OC and OCP is important in premenopausal women, which will again contribute to the increased CVD. So the women also have elevated triglycerides, and that increases the CHD risk. This is what you see. These are the men in red and yellow in women. As the age goes up, the risk factors also go up. Now, lipid levels, as you can see, men, LDL is much less than the women. Even though women have slightly higher HDL, it's not enough. Now, coming to women, smoking and coronary heart disease. This was a WHO collaborative study, of course, done in 1997, but the fact remains the same even to today. Smoking reduces the estrogen levels. Menopause occurs earlier for smokers, and women smokers have a high risk of early heart attack. For women less than 50 years, the majority of CHD is attributable to smoking. So risk increases with the number of cigarettes smoked and the duration of smoking. Now, women smokers on OCPs have a heightened risk compared to non-smoking non-pill users, up to 87 times in heavy smokers. And NHS has shown that age-adjusted relative risk for fatal CHD with non-fatal MI, especially in the, this was 3.3 times more as compared to the non-smokers. Now, mental stress is a trigger for ischemia in women more often than men. Women had more EKG documented ischemia during mental stress, men more during physical stress. So this is the difference. Now, women reported chest pain more often during daily activities and mental stress tests, men more often during physical exercise. Then perceived stress score, all this, this is was significantly higher in women. Now, psychological stresses in women with CHD, this Stockholm Female Coronary Risk Study again showed that among women who were married or cohabitating with a male partner, but marital stress was associated with nearly threefold increased risk of recurrent CHD events. So the marriage or partnership benefits men on the other hand. Now, pregnancy is another nature stress test, they say, and high blood pressure, gestational diabetes, preterm births, and all these complications during pregnancy again are known to risk the woman and pushes the woman to future CVD. Now coming to menopause and premenopause, menopause and high risk CHD is again is much more. CVD is much more as the woman grows older and postmenopausal. Now, this is the relationship between the early menopause, sorry. So having some problem. Now, relationship between early menopause and accelerated CVD. So this is a minimal or no risk pre-menopause, and then you have increased risk of CVD, and also increasing the CVD risk throughout the menopause. Now, does hormone replacement therapy prevent heart disease? I think by now we all accept that HRT at present not recommended for primary or secondary prevention of CVD. Now, areas of certainty, we have women with diabetes are at high risk of CVD and stroke. Age, menopausal status not protected. Screen all women with diabetes for CV risk factors and treat aggressively. Use internationally accepted targets for A1C less than 7, blood pressure less than 140/80, lipids LDL less than, I think it should be 70, and cholesterol, LDL cholesterol. Statin therapy for those with history of MI or age above 40 or older. Now, prevention of risk factors. The strategies included are lifestyle modification, smoking cessation, limitation of alcohol intake, aggressive blood pressure control and blood sugar control, of course, lipid control, regular ASCVD risk assessment and follow-up, regular counseling if required for women with diabetes and need to be screened for CVD risk at least once in 2 years. Despite this knowledge, substantial gaps in achieving these goals remain a true reality. So coming to summarize, women with diabetes are at high risk for CVD and cerebrovascular disease. Aggressive search for risk factors and risk stratification is necessary. Targets are the same as for men, and presenting symptoms may be different. Avoid medications that can increase CHF, ischemia, weight, and hypoglycemia. Depression and dental health, obstructive sleep apnea are also linked to CVD and they should be managed adequately. Thank you. I would end here so that I don't overstep the time. Thank you very much.
Thank you so much, Didi ma'am, for that very comprehensive overview of how women are so highly predisposed to cardiovascular disease. And it's not only at a certain age group, but I think as our age goes up, the CVD risk goes up. So this is something that we really need to focus on, not only at a certain age, but I think right from the beginning. And I request you to stay back for the discussion once we are done with all the three speakers.
Yeah.
So with that, we now move on to our next section, another very, very illuminating talk and a very dynamic speaker, a good friend, Dr. Anjali Bhatt. She is a diabetologist and endocrinologist and a founder and chief consultant at Endoclinic Pune, and very, very passionate when it comes to patient care, academics, research, teaching, everything. She's contributed many publications in journals. We've seen her very, very academically talking at different national, regional, international conferences. And she's very, very passionate when it comes to her own me time, her activities, watercolor paintings, writing, reading. I remember seeing something on a swimming competition also. So she is a visiting consultant at Symbiosis Medical College for Women and Symbiosis University Hospital. And she is going to talk on the relevance of women and bone health in diabetes. So welcome, Dr. Anjali.
Thank you so much, Shalini. Again, a very dear friend, and Rajiv sir. Very modestly, you said that 10 years old is a baby, but we know what it takes to continue this kind of academically strong conference for 10 years in a row. Thank you for making me a part of it. And thank you for giving such a wonderful topic, which is very, very relevant when it comes to talking about the effect of gender on the medical science that we are practicing today. I hope my slides are visible in the PowerPoint mode and they are moving.
No.
Slides are not moving?
No, not yet, Anjali.
No, not yet.
See your slides.
We can't see your slides.
You can't see my slides.
No.
Okay.
Now they are visible. Just put them on full screen mode. Yeah.
Is it moving?
Good to go. Yeah, good to go.
Sure. So I've designed this talk under a few headings. One is the relevance of gender in bone health. Second is at what age do we worry about bone health in our lifespan? Does diabetes make a difference in bone health and its treatment? Osteoporosis, which is considered to be one of the major player when it comes to bone health in women, and then we'll come back to the summary. So coming to first point, relevance of gender in women, a one-line factual information saying that women make up to 80% of persons with diagnosed osteoporosis will tell us what is the importance of gender when it comes to taking care of the health of the bone. Women's bone health has always been considered as equal to post-menopausal osteoporosis and post-fracture care that is required, especially in the post-menopausal phase of women's life. But slowly we are growing our knowledge to expand this definition to a preventive model throughout the lifespan. Chalini just touched this topic before this presentation started. And that is why now most of the guidelines are shifting their focus on bone health from just managing and preventing osteoporosis to improving the women's bone health throughout their lifespan. And that lifespan can start at a very young age. Again, coming to highlight the point of gender when it comes to bone health. As a developmental fact, men tend to have higher bone densities and contents. Their bone mineral content start or peak at a later age than women. This difference of bone content and density is independent of the nutrition, level of physical activity, as well as their general weight or lean muscle mass. Though we know that testosterone plays a major role in lean muscle mass, but in spite of even when we randomize these people with effect of nutrition and level of physical activity, men have higher bone mass as well as bone mineral density. Now, bone mass we can identify might be because of bone size, because they have a larger musculoskeletal structure. But bone mineral content in men is higher than women, which is irrespective of these factors. We know as a social determinants, nutritional level as well as physical level of physical activity is much better in men than women. But even if those things are taken care of as an independent factor, gender has a very strong effect on developmental aspects of bone health. At what age is the bone health relevant in men as well as women? Now, adolescent is considered to be the most critical period when bone mineral accrual happens. Almost 40 to 60% of peak bone mass is reached during the adolescent level. If something can be done at this level, a small increase in the peak bone mass of 10% at children and adolescent level can actually reduce the incidence of osteoporotic fracture in postmenopausal or adulthood by 50%. So that tells us at what age we need to start worrying about the bone health. It is not at the time of 5 years after menopause or at the time when someone develops a vertebral fracture or a hip fracture. That's the time when we think that the bus is gone and we have lost the window of opportunity to modify the risk factors. In women, the rate of bone peaks earlier than men. It is at around 11 to 14 years, while in men it peaks around 16 to 18 years. And the peak bone mass is achieved by 25 to 35. So this is the most modifiable age group window where we need to worry about bone health relevant. So preventive measures started during children and adolescent phase as well as adulthood are important to prevent the fracture risk at a later date. So calcium, vitamin D supplementation, a balanced nutrition. Children and adolescents need to involve into weight bearing physical activity, which is considered the most positive modifiable intervention. Then even in the adulthood, a balance of weight bearing and resistance exercises along with a balanced nutrition and particularly muscle strengthening physical activity, not the aerobic but the muscle strengthening physical activity, balance training, hand eye coordination training, and caution during exercises to prevent fall at a later age are one of the most important features of preventive care when it comes to bone health. Now, because we're talking about effect of gender on bone health, it's very important and pertinent to understand the effect of menstrual abnormalities and eating disorders, especially in adolescent and young girls, where they are very prone for eating disorders like anorexia and bulimia. Prolonged amenorrhea or oligomenorrhea can develop estrogen deficiency for various reasons like PCOS or eating disorders or menstrual abnormalities. And this can lead to a poor bone mineral density, poor peak bone mass, which is not realized for years after the window where peak bone mass can be modified. And at that age, I think it's very important that we take care or we realize that the menstrual abnormalities are not just about reproduction, but also about their musculoskeletal health, in addition to the metabolic health that we know is very well pertinent from the effect of the reproductive hormones. Female athletic triads, we see a lot of patients like that, where young girls involved into sports activities, where they are trying to keep their their total weight low, and because of which, and they try to increase the muscle mass, in which the low energy availability, which leads to not only menstrual irregularity for a long period of time, especially if the menstrual irregularity continue for more than 6 months of time, they can develop low mineral density, which may not get detected at that time. But over a prolonged period of time, if this continues, these people are very, very prone for low bone mineral density as well as fracture risks. Now, on one side, we have polycystic ovarian syndrome, where people are gaining fat and causing menstrual abnormalities. And the other side, we have female athletic triad, where excessive reduction of calories and excessive exercise leads to low energy availability and estrogen deficiency because of GnRH deficiency. Now, it is very common to assume that analogous to estrogen, testosterone might be the dominant hormone in men for bone metabolism. But now it is very well established, and a very interesting fact, that even in men, the major regulator of bone mineral density, bone mass, is estrogen and not testosterone. And that is why it is also interesting to understand that it is the estrogen deficiency, the periods in women's life when estrogen deficiency happens. Estrogen is the major player in bone formation, as well as the gap between bone resorption and bone formation, leading to poor bone mineral density and poor bone health. So we'll not go into the mechanistic aspects of what estrogen does, But what we need to understand is that estrogen is extremely important to fill the gap between bone resorption and bone formation, leading to good health of a bone. Now, apart from estrogen, there are other endocrine players like prolactin, LH, FSH, progesterone, as well as testosterone, which might affect the role of gender in formation of bone and bone mineral density. To cut the long story short, 2 points to understand. One is effect of gender and second is effect of age. We don't have to wait for the disease to happen to identify and treat it. But what we need to do is we work at a very early age where we can maximize the bone and muscular gain. In middle age, we need to maintain and prevent the decay or loss of the bone and musculoskeletal structure in the older age. So this is the approach, and the approach starts very early in life, and earlier or larger the peak bone mass that one achieves, lesser would be the chances of degeneration at a later date. Now, what role does diabetes play? The prevalence ranges from 10 to 50%. 50% means every alternate patient with diabetes might have an osteoporosis. It occurs at a very younger age. It is not affected by gender. What does that mean? That means that the advantage of gender or disadvantage of gender is nullified by diabetes, and both genders become susceptible for bone loss in diabetes, and it is also not affected by BMI. It is considered that obese people are slightly protected from osteoporosis, but diabetes nullifies that protection also, and that is why patients with diabetes especially need to be evaluated and considered for diagnosis as well as treatment of osteoporosis. Now, again, I will not go into the details of mechanistic information, but diabetes does have a very strong role to play in increasing the bone resorption, reducing the formation, and causing poor quality of bone. Medications, we know certain medications like pioglitazone might have deleterious effect on bone mineral density and make the patient at higher risk of developing osteoporosis and fractures. While most of the anti-resorptive as well as anti-osteoporotic therapies are very safe in patients with diabetes, so we should not make any delay in diagnosis and treating for osteoporosis in patients with diabetes. That brings me to the major topic which is considered important from the bone health point of view, and that is osteoporosis. Let me take you through a case which is very commonly seen in our clinical practice. A 56-year-old lady with BMI of 28 kgs per meter square. She has a sedentary lifestyle, known diabetes on metformin, pioglitazone, HbA1c is 7.5. Her menopause was 5 years back, and during this time, she presented with pain in lower back after a fall by accidentally jumping on granddaughter's skating board, and she was found to have a vertebral fracture. Now, when it comes to evaluation and management of osteoporosis, one person that I like to follow a lot is Dr. Thomas Paul from CMC Vellore. He has done tremendous work in bone and osteoporosis, and their paper, their data, CMC Vellore data suggests that almost 20% of South Indian men above 50 years and 40 to 50% of South Indian women above 50 years. So every alternate person above 50 years is likely to have osteoporosis, and that is how big the problem is, and that is how significant the active case finding of osteoporosis should happen in our clinical practice. Now, osteoporosis is often termed as synonymous with low bone density while done on DEXA scan or DXA scan. And what we do is we treat with a medication and we see that the bone mineral density has increased. This is not the right I would say, perspective to look at osteoporosis. While osteoporosis means what low bone mineral density means, low bone mass and microarchitectural deterioration of bone tissue. Now, what it does is it makes a person susceptible to develop a fracture if someone falls. And that is why it's important to understand it from the diagnostic pathway that starts with assessing the fracture risk. So only when somebody falls, there is a fracture risk. So we are not only assessing the fracture risk, but we are also assessing the risk of fall. And that is why bone mineral density done randomly and found to be low is not the right approach. What is important is to treat and monitor to prevent fall as well as fracture using bone mineral density as a tool. And that is why we need to assess the risk of fracture and fall as a group. There might be some skeletal fractures which are previous history of fracture, family history of fracture or osteoporosis, some secondary causes that can increase the bone turnover, and then comes the low mineral density which is found on a DEXA scan. Age is an extremely important factor to filter out who needs to be considered for diagnosis as well as management of osteoporosis. And not to forget the non-skeletal fractures like sarcopenia, uh, musculoskeletal abnormalities like some strain, some sprain, somewhere pain, and causing abnormal compensation of muscles or weakness of muscles that can make a person fall badly or fall in a wrong posture, which makes them more prone for developing a fracture. Poor eyesight, poor ball balance, poor hearing, and poor environmental conditions, like we saw in the previous case, that there was a skateboard lying and the lady fell off on a skateboard. So the environmental factors, the factors of the surrounding condition of the housing, all these things will also be very important to assess. Now, do we do bone mineral density in everyone? No, there are very clear guidelines, Indian guidelines, ISBMR, which is a very excellent document to read for everybody who is managing patients likely to have osteoporosis. So everyone with age 60, all women with age 60 or more, men 65 or older. In India, it's very common to have menopause at a very early age. I have seen people having menopause around 45. So anybody who is post-menopausal for more than 5 years, or if there are any risks or concerns for osteoporosis, women with postmenopausal transition, if there are risks, individuals who had a fragility fracture before age of 50, and somebody who is likely to have high bone turnover condition like rheumatoid arthritis, diabetes, malabsorption syndrome, or medications which can increase bone turnover like glucocorticoids should be evaluated for bone mineral density. Now, how does the pathway go ahead? A pathway for treatment goes ahead. So one is if there is a fracture, which is typical of osteoporosis, that is vertebral fracture, neck femur fracture, or Colles fracture in the wrist. These are the three fractures which are typical or specific for osteoporosis, and osteoporosis fractures are likely to happen at these stages, at these levels, at these places higher than the other places. And that is why if there is presence of typical osteoporotic fracture, we do not need any other evaluation or for that matter investigation. If you're working in a very low resource setting and if you find this, the patient can straight away be started on treatment for osteoporosis. While if you are in a high resource setting, anybody who is postmenopausal, women more than 60, men more than 65, younger people with relevant increase in the clinical risk score of a fracture. So commonly used scores are FRAX or STAR or a clinical risk score. Dr. Thomas Paul was also always referring to this, that anybody with more than 3 teeth fall is a sign of poor musculoskeletal health and likely to have a higher risk of osteoporosis. And younger men and women with a condition which will increase the risk of osteoporosis. In these people, get a bone mineral density done. If the bone mineral density is less than 2.5 T score or lower, then these people need treatment for prevention of fracture. The treatment may or may not increase the bone mineral density. So it is not necessary to keep on monitoring your treatment with a bone mineral density every now and then. There are indications to monitor bone mineral density and change the treatment accordingly. But it is important to understand that we are treating to prevent the fracture rather than improving the bone mineral density. Now, if you are suspecting a secondary cause or a complementary cause for osteoporosis, then get a routine investigation done. It's important to do certain investigations, specifically if you are giving bisphosphonates. You need to make sure that the creatinine is normal, the patient is vitamin D sufficient, patient has enough calcium supplementation, there is no thyroid dysfunction. And if at all there is a high risk, urine calcium, parathyroid hormone to rule out hyperparathyroidism, bone turnover marker if you're suspecting secondary causes. If you're suspecting myeloma, you can consider doing serum or urine electrophoresis. Or if you're suspecting Cushing's, one overnight dexamethasone suppression test might be required. Coming to the treatment of osteoporosis, we have two groups of medications. One is anti-resorptive agents, which are bisphosphonates and the monoclonal antibody denosumab. And there are anabolic agents like teriparatide. Now, how to choose this? Again, Dr. Amrish Mittal's lecture on this topic is fantastic to understand and how we make a choice of the therapy. So, if there is a prevalent vertebral fracture, there is a very strong data for teriparatide subcutaneously given for 2 years, followed by other anti-resorptive therapies. If teriparatide is not possible, zoledronic acid also has good data and can be given very easily. Then you choose denosumab as third line and alendronate as the last option. While if there is a prevalent hip fracture, then zoledronic acid has the strongest data. Teriparatide still doesn't have data about for the hip fracture. As a second option, we can give for denosumab, then alendronate, and then teriparatide. So this is the line of order of medication, choice of medication when it comes to treatment of fractures. Coming to any modification while we are treating patients with type 2 diabetes and osteoporosis, lifestyle interventions are very common, especially nowadays. The low calorie diets are very, very prevalent in patients who are trying reversal of diabetes therapy. When it comes to gender consideration, what we have seen is that when someone loses weight, women tend to lose more lean muscle mass compared to men. So if men and women are losing equal weight, it is men who will lose more fat while women will retain fat and lose more muscle mass. That's why when gender is considered, it's important when we are giving low calorie diets, we make sure that we are giving enough protein and we make sure that we are doing enough strength training to make sure that we are not making the person sarcopenic while we try to make them lose fat and reverse the diabetes. It's important to avoid medications that might have deleterious effect on bones, especially pioglitazone. Other medications, I would not say that you need to avoid if the benefit to risk ratio of treating hyperglycemia is favorable towards benefit than the risk. While treatment of osteoporosis must be considered in every patient who is found to have at a higher risk and low bone mineral density, and the general guidelines for evaluating them should be followed. Coming back to the case that we have discussed, what are the factors in this particular case that are pertinent? What should we consider when we try to evaluate these patients? 54 years, though it is not a very common age for osteoporosis prevalence, but because the menopause happened at 51, it's important that we need to consider that it can come at an earlier age. Sedentary lifestyle means that the muscular strength is not very strong. Pioglitazone, another factor which might let us, which suggests that we need to consider about preventing as well as treating osteoporosis. And accidentally jumping is an information given to highlight how important it is to evaluate the environmental factors also when it comes to treating these patients. Now, the lady standing on skating board is a representation of managing bone health from a very early age to make sure that even with an advanced age, you are able to manage to avoid fall and the risk by improving, first, improving your attainment of peak bone mass, second, to maintain the muscular strength at a middle age, and then trying to prevent the fall at a later age, which will balance out and by completed by the fourth parameter, that is active case finding of osteoporosis and proper treatment. So bone health in women with diabetes, as I said, good physical activity, earlier the better, calcium and vitamin D supplementation in relevant cases, active case finding for appropriate treatment for osteoporosis, avoid unfavorable medications when especially it comes to patients with diabetes, and prevent falls by improving the environmental condition. With that, I would like to say thank you again for involving me in this wonderful conference, and I will be happy if there are any queries regarding this topic.
Thank you so much, Dr. Anjali, for that very comprehensive coverage and stress on bone health and why it is important to be very, very careful about your bone health right from the beginning rather than actually thinking about towards the perimenopausal time when you know with most of them are already osteopenic or osteoporotic. So we'll request you to stay back for the questions after the next speaker. Thank you so much. And now we have none other than our Akka, Dr. Usha Sriram, the flag bearer of everything related to women and diabetes. And we just celebrated 10 years of Divas with her very, very recently. Welcome, ma'am, to the 10th International Symposium in Diabetes. And she is the flag bearer for gender differences, gender specific guidelines when it comes to management of diabetes in women. And we'll have ma'am shed more light on this favorite topic of hers. Welcome, ma'am.
Thank you, Shalini. All I have to say is congratulations to you as well for the 10th anniversary. And let me just start, sharing my slides, and then we can. So I really appreciate, this whole conference and you and Dr. Chawla for all the hard work that you have put into this program. And I have been listening to Lily and Anjali, and both were amazing talks and have set the stage for this whole. Is it time for gender-specific approach to diabetes care and guidelines? And I think after their talk, we should be convinced that it is. But let me give you a few more details. And thank you for giving me this talk. And we all know that in 2017, the IDF made the theme for World Diabetes Day as Women and Diabetes, which completely, I think, changed the landscape and validated it. And they also said that diabetes adversely affects women more than men. And I think that was a very important validation of what we are trying to talk about and legitimized everything. So what is wrong with this picture? As you can see, whether it's blindness, heart attack, kidney failure, nerve damage, amputation, stroke, whatever, everything is a male image, except pregnancy is the only one they've got a woman's picture. Even this kind of representation, this optics, again tells us that somehow we have been gender blind when it comes to this, or even gender neutral, which itself is not a good thing, because we know that diabetes affects women adversely. Just a couple of things, this whole gender equality is also part of the SDG global goals. And in addition, as you can see, good health and well-being and everything is kind of goes along with the using the gender lens. And if you see, patient-centered precision medicine defines 21st century healthcare. And viewing the patient through a sex and gender lens is a very important step, or a first step towards personalizing care. How can you get, more personal than making it specific for men or women? And as first thing is, we need to recognize that sex is biological, men, women. But gender is something that is largely dependent on social and environmental factors, behavioral factors, and throughout the life, while there is sex and then epigenetic modifiers, then gender modifies a lot of things, especially when people develop diabetes. There are many biologic differences between men and women, and as I like to say, men and women are equal, but definitely not the same. At every level, there are lots of differences. And as you can see, there are physiologic and pathologic sex differences when it comes to the whole diabetes and metabolic milieu. And when you look at drivers of diabetes, the usual urbanization, globalization, obesity, sedentary lifestyle, genetics, and all of that applies to men and women. But then there is a whole slew of other things like pregnancy and GDM and PCOS and menopause. And if a woman is low birth weight, she's at greater risk for gestational diabetes later in her life. And if her mother has diabetes, she's at greater risk for diabetes. Then there are, when it comes to this gender thing, women are typically caregivers across the globe from childhood up to old age. And caregiving itself is a form of stress, and it's a driver of diabetes. And it's a very gender specific thing. And poverty, the 70% of the world's poor or more are women. And then if you look at a woman's life, whether it's puberty or menstrual cycles or the preconception time or pregnancy, breastfeeding, PMS, perimenopause, postmenopause, all of these times are associated with metabolic changes, weight changes, food cravings, so many things like that, that we should look at women not just as, talk about lifestyle with them, but their life cycle. So for women, there is both life cycle and lifestyle that changes everything. For example, you take this household air pollution. This is largely a gender issue, and we now know that air pollution is a driver of diabetes, driver of obesity. So just to point out, take this. For example, when women have a baby, not just the gestational weight gain, there is also post-gestational weight gain or weight retention, which, as you can see after the first pregnancy, second, and later in life, this, retention of the weight or excess gestational weight gain further, augments their metabolic complications, something that men don't have to go through. So it's something to do with their life, style and their environment, plus their, biology. And then if you see from this, there is all this whole social construct of gender. There's, the race and class and age and inability, all of this, when it's a gendered social position. And we know that women have we should be very happy about what happened in the parliament and government yesterday. But the whole gendered social position again makes them more vulnerable. And what COVID-19 did was, again, when it comes to, you look at the not just the non-communicable diseases, maternal, child health, everything, reproductive health, all of that got, pushed back, or funding did not happen because everything went towards COVID. So again, we're going to see more of the problem in the coming years. This talk is not a battle of the sexes at all. It is actually just an effort to make women's challenges fully visible to all, so that we start looking at this whole thing differently. The reason is the experience of diabetes is different in women. Diabetes has more serious adverse outcomes in women. The life cycle of women is completely different. The economic, social, context, that's very important. And gender specific health research. Women have not been, as Lily mentioned, not been included in research for the longest time. And gender inequities in healthcare need to view therapeutics with the gender lens. And then how gender mainstreaming has such, benefits, as I'd like to say, downstream benefits. We all know these numbers are enormous and they just keep going up. And we know more recently that we have over 100 million people with diabetes in India and about 136 million people who have got pre-diabetes, and half of them are women. But if you look at this, both in India and globally, the lifetime risk of developing diabetes in urban metropolitan Indian adults, more in women. I showed the drivers. And something like GDM, for example, increases the risk of type 2 diabetes in 5 to 10 years, within 5 to 10 years of the index pregnancy. And women have babies in their 20s and 30s, which means they're going to develop type 2 diabetes in their 30s and 40s, and therefore have a whole life when they could develop complications. And for example, gestational diabetes increases risk of diabetes in their offspring. They have greater risk of diabetes happening in subsequent pregnancies. And each time they have GDM, their risk of having type 2 diabetes or CV risk, as shown in this picture, increases. And so does obesity and abdominal obesity in their offspring. Therefore, I'm just saying, having an entire generation of having people at high risk for diabetes. And my prediction is in the next 5 years or 10 years, more women will have diabetes across the globe because of increasing PCOS, obesity, post-pregnancy, post-GDM, the post-menopause, and women are living longer after the menopause and increased risk of pre-diabetes. So all of these are going to push more women into the whole, diabetes space. But unfortunately, so what if more women have diabetes, right? No, more women die when they have diabetes across the globe, except North America. So this is something very troublesome. And why is that? As Lily showed us, more heart disease, more and more coronary heart disease, more stroke, more vascular dementia, more end-stage kidney disease, more fractures, more cancer. Anjali told us about osteoporosis in people with diabetes. The INDIAB data from India has said that in India, more women fracture if they have diabetes than men. And diabetes seems to be particularly a risk factor for fractures in women. So, and depression is much more common in women compared to men. So for all these reasons, diabetes is much more serious. And I've just quickly run that more women have heart disease. And then this is a study from Nandita Arun, where they showed secular trends in cardiovascular risk factors. And they showed that the increase in risk of all the cardiovascular risk factors, hypertension, diabetes, dyslipidemia, pre-diabetes, and then in the symptoms are different, therefore is likely to be missed. Stroke, which is something seriously ignored by most practitioners. We talk about heart disease, but stroke is, we should remember, as a brain attack, very, very common. And also hypertension is very prevalent in women. And stroke is more. Diabetes as a risk factor for stroke in women compared with men, and in systematic analysis has shown significantly higher in women. I told you major depression is more common in women. And as soon as menopause happens, see what happens. Within 6 months, the HDL goes down and the LDL goes up in women. And in an already pro-atherogenic state in people with diabetes, the menopause is going to amplify those risks. And this is a study from Dr. Mohan's group and Dr. Tandon's group that showed that pre-diabetes is higher in young women. And what is the problem with pre-diabetes being higher? Of course, they are all in reproductive age, increases the risk for GDM. But this is what I want to show you, that sex differences in visceral and subcutaneous fat and association with time of diagnosis of diabetes. So they stay in this pre-diabetes phase a little longer till they accumulate more fat. But in this time that they are accumulating the fat, they're also accumulating CV risk factors, which is what is making them more prone to heart disease and increasing their morbidity and mortality, which is very worrisome. And then, of course, everything is delayed. Delayed diagnosis of diabetes, delayed diagnosis of cardiovascular disease. There's no lifestyle education as a national program, and all of this compounds. And this is the NDIAB data I was mentioning, Anjali. After gender stratification, diabetes was a risk factor for fracture only in women in our NDIAB data. And so all of these things, and Anjali correctly showed us how we should be careful about what medications that we are using, especially no pioglitazone and agents like that. Aside from all this, there are many socio-cultural aspects of diabetes in women. We are anxious about other things, about expense. Will it affect my marriage? Will it affect my baby? What will my in-laws think? Will I be able to take care of my baby? Will I gain weight? Who's going to pay for this? So these are all things that worry women much more than for example, they worry men. And then there's, when it comes to obesity, there's going to be a session on that. There's more obesity in women, which has to do with their lifestyle, and maybe they are forced to be in that lifestyle. Women may not have the agency they need. Their life cycle predisposes them to obesity. And then, of course, psychosocial, the social norms that makes women, gain more weight. I'm coming to the end of my talk. So putting all this together, guidelines, policies, and best practices have to be developed. Till now, gender has not been factored in. I'm showing you over the years, all kinds of guidelines have come out. Type 2 diabetes management algorithm, 10 points have been given, nothing about pregnancy, nothing about women. And same thing, they've got all the drugs there, nothing about pregnancy, nothing about women. Look at this beautiful, wheel that the ADA ESD came up with. They've got everything included there except gender. They have everything included there except, women. So this is, I think, very disappointing. And this is something that we must, under principles of care, it should actually be under components of care. We should first look at, is it a man or a woman? And if they are women, are they in their reproductive years, or are they in their peri or postmenopausal year? If they are in their reproductive years, are they planning a pregnancy, or are they not using contraception? Are they using contraception, family planning done? Then what we need to focus on. If they are postmenopausal, what do we need to focus on? If they are going through the perimenopause, what do we need to focus on? Because it's all different. One size absolutely does not fit all. Unplanned pregnancies in type 2 diabetes, nearly 50% end up with anomalies, and now more of cardiovascular anomalies. And different drugs seem to have different effects on men and women, for example, GLP analogs or SGLT2. So we need to be cognizant of so many things like that. And, our group of women, both in endocrinology and diabetes, we came up with this kind of an algorithm, which we are now trying to see if we can, propose to the international societies to say, let's take a more, gendered look at diabetes and change our guidelines, because guidelines provide us a critical appraisal of existing evidence. A roadmap is made available for providers, ease of decision making, validated by professional bodies, a reference document for consultation and standardization, and it improves outcomes. So for years, we've been trying to fit a round peg into a square hole. Time to change all of that, because one size does not fit all, and diabetes in women is not the same as diabetes in men. Thank you so much.
Thank you so much, Usha ma'am, for so beautifully telling us how things are very, very different, because we always feel that what suits a man suits a woman. So, the same kind of algorithms, no distinguishing between a woman and a man. Forget about the different life cycles of a woman, different stages of a woman's life. Like how Anjali stressed upon the bone health part.
Absolutely.
So I think these are very, very pertinent questions. My question to all three of you is, we now understand that yes, things are different when it comes to a woman's life cycle, even when it comes to how diabetes needs to be managed, the trajectory of complications that happens, the cardiovascular disease risk that goes on. So what do you think is actually needed at a ground level to actually shake things up and to actually start doing something about the numbers? I mean, we've all been talking about it for so long. The awareness levels still in the population don't really seem to be as they should be. And when it comes to our own community, how proactive are we in actually addressing these problems when it comes to the differences between men and women when it comes to bone health, to cardiovascular health, and overall health? So, I mean, this is an open question. Maybe all three of you can give us your thoughts. Lily ma'am.
Yes, thank you, Shalini, for that wonderful question. Because after all, coming together for the conferences, if it doesn't give us thoughts to provoke provoke us to do in practice, it is of no use. So what after listening to Dr. Usha and our Anjali and all the other speakers even before that from Egypt, I think what we need to do is all of us, just like an INDIAB study, all of us at our own level, we should make a small studies and compare them with men and women and make noise about, women are different. Women need more care and more guidelines. Guidelines specific to women are a must at this stage. And then if we make enough noise at our own level, I think all of us, all active women like us, should do something or plan something for our country and make a noise and take it internationally.
No, but then, Anjali, if you want to come in, what do you do as a person? What am I supposed to do as a person? As a group, yes, we've been doing that, making representations and doing all those things. But as a person sitting in a clinic today, what is your message to all the healthcare practitioners listening to us on this very important topic? Small steps can be the beginning of a big movement.
As a group, definitely we are trying to make sure that there is research, there are guidelines, there are recommendations. But as a clinician sitting in the OPD, I don't think we are thinking gender as one of the very important factors when we plan a person's treatment. So whenever a person is coming and sitting in front of me, I diagnose her or him to be diabetic, the first thing should come to my mind, is it a man or a woman? And like Usha ma'am very nicely said, if it is a woman, I don't think many of doctors are even talking to the lady patients about whether they are in reproductive age group, are they even planning conception, are they sexually active? So these are the questions that are not talked about to our patients. And more so when a man doctor is treating a woman patient. I think many a times a woman doctor will probably ask these questions to women patients, but men doctors are not even talking about these topics to women patients. And it is so pertinent. If a 30-year-old lady comes to you, you start her on a SGLT2 inhibitor and a statin, and tomorrow you come to know that she had missed her menses last time, or she doesn't know that she's pregnant, or she plans or she gets an unplanned pregnancy 3 months later. So these are disasters that can be avoided, that must be avoided, that must be avoided. So I think considering gender, of course, going ahead one step, we talk about diseases that are more common in particular gender than the other, like bone disorders, cardiovascular disorders, importance or relevance of the age in. So this goes without saying, but I think the first consideration of gender being an important, we're calling it as a demographic factor to be recorded in an EMR or a file. But it is a very important point while we decide or plan the management. And I think that is not happening at the ground level.
Absolutely. So I think, yes, we are aware that things are different and we really need to bring it down to our day-to-day practice. Because I think small changes that we implement in our own individual clinics eventually can lead on to a big change over the years. Usha ma'am, a quick take-home message from you to all our audience before we move on to the next symposium.
Every patient who walks in, I think the first thing that we have to do is it a man or a woman? Okay, and then just go, and trans women come under women. Trans men come under men. So you do, you do like that, and then you just apply the algorithm that we talked about. There will be no errors. So it's just a question of training our mind and getting used to that for a little bit. That's all. And that's exactly what I'm trying to talk to the ADA. Have 2 sets of guidelines, women, men. We get used to that in no time, and afterward it becomes second nature. See, now I don't have to look at a guideline. I know if they have ASCVD, CKD, it is SGLT2. We know the algorithm, we know the drill. So after some time, this will become second nature. But till it becomes second nature, it has to be on paper and also, I think, sort of mandated.
Absolutely. So thank you so much, ladies, for that excellent deliberation on the very, very important topic. And I think all of us are champions in ourselves when it comes to the cause of women and diabetes. And like I said, small steps can actually lead to a big change. And we're already taking those steps. And I'm sure we'll see the change over the years. Thank you so much for this. And we'll come to the close of this symposium. Thank you so much, Dr. Lily, Dr. Usha, and Dr. Anjali for your deliberations.
Thank you. Thank you very much.
We now move on to our next very important symposium on another very, very important topic, a very pertinent topic, obesity. And this is something that all of us encounter in our daily lives, be it our clinics, be it our homes, be it our friend circle, because everybody wants to know it's not only about the body appearance, but the metabolic problems that you face because of obesity. And I request Dr. Anjali and Dr. Usha to continue with us as chairs for this very important session. Can I have, yeah. So Dr. Usha, could you please introduce our first speaker, ma'am?
Yeah. Can I have the, yeah.
Yes, ma'am. Can I have Dr. Nita's CV? Yeah.
Okay. So this is an absolute pleasure and joy to introduce a dear friend, Nita Deshpande, who's also, done major work and is committed to the to bariatric medicine in India. And Nita is a diabetologist and like I said, bariatric physician from the Belgaum Diabetes Center, the Children's Diabetes Center, and associate professor of medicine at the USMKLE International Medical Program. Several presentations, which we are all aware of, has held many important positions. And more importantly, I just want to say that Nita has consistently worked in this space and really now a very important thought leader in bariatric medicine in India. So Nita.
Jusha. I think my recording will play now.
Go. She's traveling. RX, can you just contact Nita, ma'am?
Me to be a part of this academic extravaganza. Thank you so very much. So the topic that I have been assigned is obesity redefined. So let's see what obesity definitions are and why it needs to be redefined. I shall start by sharing my screen. Yes. So here we see that obesity has been in the storm of controversy because it has certain definitions in the past, and now those definitions are being challenged. And let us see why that has become necessary. So the current definitions of obesity are many. The World Health Organization says that overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. So please note here that it talks about fat and not weight. Then you have the ACE relabeling of obesity, where they have relabeled the term obesity as adiposity-based chronic disease, or ABCD for short, a condition that goes beyond the traditional focus of the body mass index. So here again, the body mass index has been kind of sidelined to include other definitions of obesity. However, the Center for Disease Control and Prevention, the CDC of the US, still defines obesity as weight that is higher than what is considered healthy for a given height. That means BMI. And this is described as overweight or obesity. So what actually should be the definition of obesity depends a lot upon its current status as a disease. So there are a few countries which have already labeled obesity as a disease, and that is why the definition has come under scrutiny and review. So why should it be redefined? Because if obesity is a disease, we better be careful who we label as having obesity, because you're giving a stamp of a disease to somebody and not just some cosmetic issue. So a proper definition must avoid both overdiagnosis and underdiagnosis. Why is this necessary? Because it has implications for treatment, and therefore it was decided that obesity needs to be redefined because it's a disease. Now, what's wrong with the previous definition, which was simply the BMI, that is, weight for a particular height with cutoff values? I'm not going to discuss the cutoff values. I'm going to discuss the concept of what should be included under the definition. So, if you look at a BMI based definition, there is a risk of overdiagnosis because many who would be labeled as diseased by virtue of their body mass index may in fact be in good health without any disease whatsoever. On the other hand, at the other end of the spectrum, there could be an underdiagnosis of obesity because there may be many who have health impairment on account of excess body fat, not weight, mind you, but excess body fat. And these people would surely benefit from obesity treatment, although they may not exactly reach the definition of obesity by way of body mass index. And therefore, a purely BMI based definition suffers from fallacies of overdiagnosis as well as underdiagnosis. And also, if you look at the statistics, about 50% of individuals not labeled as obesity by BMI might indeed have excess adiposity. And up to 30% of obese individuals, BMI more than 30 by Western standards, are relatively insulin sensitive, contrary to popular belief, and therefore do not have cardiometabolic disease. On the other hand, up to 30% of lean individuals have insulin resistance. A lot of Indians would fall into this category, and these people may have cardiometabolic disease manifestations. Therefore, BMI is a poor discriminator of CV risk, especially in people with an intermediate BMI below 30. So we don't know really whether these people have cardiovascular risk or they do not have it, though they fall into the definition of obesity by way of BMI. Now, we all know that obesity can exacerbate insulin resistance, but insulin resistance exists largely independent of BMI, and therefore the BMI could be a poor predictor of CVD when compared with other measurements such as waist hip ratio and only waist circumference, which I'm going to come to a little later. Now, with only BMI, if only BMI is used, we may ignore normal weight obesity people. And this is an under-recognized problem, especially in individuals of South Asian descent. So you can see here that one end of the spectrum, you have people with normal body mass index. And on the other, you have morbid obesity. And in between, you have all the overweight and obese individuals by BMI. But if you look at this tiny sliver of brown, where the weight is apparently normal by way of BMI, but they could be having problems. They could be having problems which are metabolic. So that is, they may be having excess amount of fat. And that is the reason that we call these people as normal weight obesity, normal by way of BMI, but obese by way of body fat or cardiovascular risk. This is a very famous slide. Years ago, it has been published. And this exemplifies what I have been telling you all this while. Two people, stalwarts in the field of diabetology, Dr. Yagnik and Dr. Yudkin, the YY paradox, both having the same BMI, but look at the change in body fat. So body fat was much higher in Dr. Yagnik versus his European counterpart. And that is the fallacy of BMI. Also, BMI cannot identify changes in body composition. So if you look at this, body composition changes with age. So a person may remain at the same weight, but his body composition has changed, which cannot be identified by BMI. That means sarcopenia cannot be identified. And we all know today that sarcopenic obesity is a huge risk for cardiovascular disease and so many other problems as well. And this cannot be identified by BMI alone, because the increase in abdominal or visceral fat, which contributes to the change in body composition that happens with age, cannot be identified by means of BMI alone. Again, BMI is insufficient to predict the mechanical and metabolic consequences. So if you look at obesity, if there is sarcopenia, there is an increased risk of falls and fractures, causing physical disability, which cannot actually be predicted by a BMI alone. And so also insulin resistance, as I have alluded to a little earlier. So what is the solution? What do we do? Do we redefine obesity completely? Do we do away with BMI completely? So what's the solution? So another doyen of obesity, Dr. Arya Sharma, has said that a definition of obesity that requires the actual demonstration of health impairments likely to be attributable to abnormal or excess body fat via a clinical assessment would ensure that obesity is only diagnosed in individuals who actually have a health problem and would therefore likely benefit from obesity treatments. This may well include individuals below the current BMI cutoff. So what Dr. Sharma says is that you have to identify those people who are likely to benefit from obesity treatment by first identifying obesity related health issues that are already there. And this may include people who are below the current BMI cutoff. So please keep this in mind, because I'm going to allude to this again. So because of this, Dr. Sharma came up with the Edmonton Obesity Staging System, which looked at stages of disability based on medical, or we call them metabolic problems, mental problems, and functional, or we also call them mechanical problems. And they go all the way from stage 0 to stage 4. But mind you, the cutoff point for assessing somebody here is again a BMI. So we have not really done away with the BMI in this. We are only staging them. And why are we staging them? We're staging them to find out who are the people likely to benefit from obesity treatment, or who are those obese individuals who need treatment most. So the EOSS is more, rather than just assessment, it is assessment for readiness for different modalities of obesity treatment. So at the end of my talk, I'm also going to tell you a few fallacies that I would say, not fallacies, but certain problems that are there even with this system. But this system is largely taking into account the comorbidities, not just metabolic, but also functional and mechanical. And this is how the examples of the staging are given. For example, a person may have a BMI in excess of 30, but you can see here that he could be at stage 0. That means there are no risk factors, no symptoms, no psychological symptoms, no mechanical problems. So this person is at stage 0 and probably doesn't need aggressive treatment according to the EOSS. Whereas when you go from stages 1 through stages 4, there are different degrees of disability in all the three categories that I talked about. And these are the people who need treatment according to the EOSS. And a study was done where EOSS staging was applied to the cohort of people who were there in the NHILs. And if you look at them, if you look at the first part of the slide, where the proportion that are surviving, so these are mortality statistics. And if you look at the first slide, I mean the left half of the slide, it is based on the EOSS, that is, they're staged according to comorbidities. And on the right side, yes, the same cohort is staged only according to BMI. And you can see that mortality is predicted very well by staging of obesity according to the EOSS, rather than just BMI, where all the lines are merging together. So BMI could not predict mortality. And that is the importance of the EOSS. On a very large population, this study was done. So after this, the American Association of Clinical Endocrinologists, the ACE, also adopted this, adapted it and modified it to have a similar staging of obesity. And that is how you have this definition of obesity, where the diagnosis, the staging is done exactly like what I had showed you. That is, these are the anthropometric components where people could be of normal weight or they could be overweight and obese. But when you look at the staging, it depends upon the disease stage, depends upon the complications. But when you look at the management part, why I like the ACE is this. This means that even if a person has a BMI of more than 30 and is at stage 0, you will still treat him, because here there is an issue of prevention. So you are going to prevent something that is coming in the future. So lifestyle therapy as well as weight loss medications are still warranted, even if the stage is 0. And here there is an element of preventive action. So the ACE algorithm also talks to us about the medical care of patients with obesity depending upon the stages and what is to be done and the phases of chronic disease prevention as well as treatment goals. So they've not just talked about treating obesity only in those people who have a problem, but also preventive action. As you can very well see over here, even those who do not have obesity, they can have stage 1 or stage 2, and these people will be treated accordingly. This is the clinical component of medical diagnosis of obesity according to the ACE. So you could have two sets of people. You could have people who have come only for obesity. These people need to be evaluated for all these complications, and then the decision for weight loss therapies to be taken. On the other hand, you may be faced with patients who have directly come to you for any of these issues. That means they already have some disease. Then these people who come for these kind of diseases, you need to now evaluate them for obesity. So you go in the reverse direction. This is a very useful concept of looking at a patient who comes to you. Has he come to you for obesity? Then look for comorbidities. Has he already come to you for comorbidities? Then look for the degree and stage of obesity and then decide about weight loss therapy. So now the debate is metabolically healthy obesity. I'm talking about those stage 0s, obese but no metabolic problems, versus metabolically unhealthy obesity. So do you treat these people versus these? That means these people will of course be treated because they're metabolically unhealthy. But MHO, do you treat them or not? That is the debate. Because if you use the latest EOSS, for example, it would say that the MHO, the treatment is not warranted at this point of time. So this debate continues as to whether individuals with MHO are truly free of adverse CVD outcomes. That means today you're seeing a patient, he's metabolically healthy. Is he really free of adverse events when compared with metabolically healthy non-obese individuals? In some studies, those with MHO, metabolically healthy obesity, have a similar risk of CVD as those who are metabolically healthy and non-obese. So mind you, today that person has MHO, but tomorrow he may become an NUO. So that is what worries CVD than the metabolically healthy individuals who are not obese. It is debated whether any form of obesity can ever be considered healthy, and this is the moot point. Any obesity, no metabolic, no mechanical, no other problems, do you consider them healthy or not is the question. Or is it that a MHO today is merely in a stage of transition to developing MUO over time? So are you justified in denying treatment to that MHO today? That is the question, that is the debate. And added to that, there is no universally accepted standard for defining MHO. Previous evidence has shown that metabolically healthy obesity is likely an unstable phenotype, which means underestimating risk based on MHO at a single time is still an issue, because some of these individuals will transition to becoming unhealthy over years of follow-up, and this transitioning can be quite substantial according to some studies. So the limitations of not treating a metabolically healthy obesity are that the definition of MHO limits itself to metabolic consequences only, and it does not take into account the mechanical problems such as osteoarthritis of the knees, OSA, cancer, etc. And mental issues related to chronic obesity can ultimately lead to increased morbidity and mortality. So, not treating metabolically healthy obesity is actually against the principles of preventive medicine because they may transition to MUO. So, it's our duty to actually prevent it. So, that is where there is a slight difference between the EOSS and the ACE definitions of obesity, where the ACE says that even if it is stage 0, you need to treat obesity. So, treating according to stages of obesity, that is, after the dysfunction is identified, is more of damage control. That means you stage the person only if he has already got health issues, you treat him. So, that means you are treating diseases. You're not preventing diseases. So, that is still a debate. So, to conclude, obesity is both a chronic disease in its own right and a primary contributor to other leading chronic diseases. So, that is something to be taken note of. In the clinic, obesity is still best defined using commonly available tools, that is BMI, waist circumference. But the hope is that we will get better imaging techniques and then we'll be able to make out fat percentage, where the fat is located, etc., which can be a little easier. So, a comorbidity-based definition is practical, but may not be in the best interests of preventive medicine, is what I would conclude with. So, the final analysis at this point of time is use the BMI, but also do not ignore fat, fat percentage, and location of fat. And I would say that every obesity needs to be treated at least to a certain extent. It may be just lifestyle, but people have to be made aware and it has to be treated because it could very well be something that is in transition. So treatment decisions would ultimately have to be customized. So thank you all for very patient hearing, and I would like to take questions if there are any. Thank you so much.
Thank you, Neeta ma'am, for that excellent talk. And do you mind staying back for the questions once we're done with the other two speakers?
Okay, we can do that.
Thank you so much. Thank you.
Yeah. Okay.
So after that excellent discussion on obesity and a kind of a perspective on what exactly is obesity and what are its implications, we now move on to our next speaker, Dr. Nitin Kapoor, who's going to enlighten us on a very important part, a topic called sarcopenic obesity. For all of us, we know him well. He's professor in Head Unit 1, Department of Endocrinology, Diabetes and Metabolism at CMC Vellore, and numerous awards, fellowships, and whatnot to his credit. A great academician, more than 240 PubMed indexed peer-reviewed publications in national as well as international journals, and has spearheaded the write-up and is editor of the current and previous edition of the book, A Practical Guide to Diabetes Mellitus, released in October, as well as he's been on boards of numerous publications, journals, and what. So, welcome, Dr. Nitin. And he's going to talk about sarcopenic obesity.
Thank you so much, Dr. Shalini Turkey, for the kind introduction and for the invitation, even to Dr. Rajiv Savla, sir, for having me here today. And the next couple of minutes, I'll talk about the topic on sarcopenic obesity. We've heard a splendid lecture by Dr. Neeta Deshpande on obesity, and what my job is to add a component of muscle as well on that. So I would cover this topic by answering 3 simple questions that we all need to know. We'll talk about what, why, and how. So we learn is what is sarcopenic obesity, the concept, the definition, what is the prevalence globally and in the Indian setting. We'll also see why. Why is this topic important to us as clinicians? How does it really change our clinical practice? What is the impact on metabolic health that this particular entity has? And the most important question, again, as treating physicians, we need to know how do we manage once we've been able to diagnose or identify a patient with sarcopenic obesity? What is the role of diet, medications, role of exercise? So getting on straight with the topic and talking about what is sarcopenia and what is sarcopenic obesity, I think all of us would agree that we are coming into an age which is called as the gray dawn or the gray wave. And what we mean by this particular term is that our population is gradually becoming more older. The number of aged people in our population is increasing. This is mainly because our life expectancy has been increasing, which is definitely a very good marker of medical health. When we look at the life expectancy across different states in India, we see that some of the states are actually at par with the Western world, telling us that, yes, we are going to be having a more aged population in our vicinity. And therefore, as healthcare physicians, as practitioners, I think we have to be ready to deal with problems in the elderly in our day-to-day practice. And definitely having high body fat and low muscle is one of them, because as we age, as we gradually age, the muscle component becomes less and the fat component becomes more. And if I was to put this in a very simple 2x2 table, I would say that sarcopenia and sarcopenic obesity can simply be understood by comparing muscle mass versus fat mass in this 2x2 table. So if we have a low fat mass and a high muscle mass, we would say we are normal. But the moment the muscle mass is low and the fat mass is high, we reach to what's known as sarcopenic obesity. But before going on to that, let us understand what sarcopenia is. And if we were to define sarcopenia by standard global definitions, we are talking of three broad entities. We are talking of the physical function of the muscle. We are talking of the strength of the muscle. And then we are talking of the mass of muscle. So we're talking of muscle function, muscle strength, and muscle mass. And all these three things are slightly different, assessed separately. So how do we assess muscle function? Well, simply we can just look at the gait speed of a person. So if you ask a person to walk a particular distance, maybe say a 6-meter walk test, and we find out the time that the patient takes to walk that 6 kilometers, and that speed would tell us whether that is appropriate for that person based on their gender or not. When you talk of muscle strength, this is something, again, which can be done with the help of something called as a hand dynamometer, wherein we are looking at the muscle strength, looking at the grip strength of the wrist. And again, we have normative cutoff based on gender. A similar thing can also be done with the lower limbs as well. Apart from muscle function and muscle strength, the third thing is muscle mass. And when we talk of muscle mass, there are several ways of assessing muscle mass. But I would say that the assessment of muscle mass using body composition would be the best way forward. So after we've assessed these three things, we can see whether our patient has lower muscle mass, lower muscle strength, or lower muscle function. But based on that, if my patient has only lower muscle strength, I would call that patient to have probable sarcopenia. If this is coupled with lower muscle mass, I would say they have sarcopenia. But if all three are present, I would say it's severe sarcopenia. But how many of us can actually do this in our clinic, our busy clinical practice where so many patients are waiting? Can we really afford to do all these battery of tests, or can we do something simpler to screen the high-risk patients and then do what is required in more detail for a certain subgroup of patients? And yes, for this, what we have is the simple SARCF questionnaire, which is a very simple questionnaire. Just 5 questions to be asked. Each question would just give us an answer of 0, 1, and 2. Based on that, if we get a score which is more than equal to 4, we would say our patient is more at risk of sarcopenia. Well, if you don't want to do that, you can also look at something even more simple, like the way we were talking about measuring waist circumference, fat, BMI in the previous lecture. Yes, you can also assess calf circumference in clinical practice. Again, there is normative value based on gender that can be looked into. And yes, if you have any of these parameters which are positive, either a positive SARCF or a calf circumference which is abnormal or low, then you can do the other 3 tests and diagnose a patient to have sarcopenia or sarcopenic obesity. But again, how many of us do have access to body composition analysis? This is the South Asian Working Group consensus that we wrote a couple of months ago, looking at how we can use simple parameters in clinical practice rather than depending on hand dynamometer or DEXA scan for all patients. Is there something simple? So yes, there are simple anthropometric measures which can be used as surrogates for patients to assess sarcopenia, and this good 40-page document talks about it in more detail. When we talk of the problem of sarcopenia from an Indian setting, yes, our cutoffs are definitely lower than the West. Again, for appendicular skeletal mass index, whether that's the skeletal mass or whether we talk of the hand grip, both the cutoff is lower. The study from PGI Chandigarh clearly showed that even in younger people, we have about 3 to 4% of people who have sarcopenia. The mean age in the study was just 44. But yes, given that we as South Asian phenotype have problems with obesity and muscle mass much lower, at much lower thresholds, definitely our problem is much bigger. This is a study that we did in Vellore a couple of years ago, looking at prevalence of lean people with obesity. Again, lean referring to lean muscle mass, and they seem to have diabetes, about 1 in 20 of them. Another of our studies, this looked at the cohort of normal weight obesity, something that Dr. Nita was talking about in the previous lecture. Again, this is a phenotype commonly seen in our setting. And the point that I'm driving it as that if we have more fat in our population, in that given individual who has more fat, we need to reduce something if the BMI is not more. And what is unfortunately reduced is the muscle. So it's often common that people with normal or lower BMI, if they have high fat, they are ought to have lower muscle. And this takes me to the concept of sarcopenic obesity, where there is not only lower muscle mass or sarcopenia, as we learned in the previous few slides, but when this is coupled with a higher body fat percentage, we call our patients to have sarcopenic obesity. A higher body fat percentage, again, there's a lot of dilemma as to what should be normal and abnormal. The American College of Clinical Endocrinologists gives a cutoff of 35 and 25% for women and men, respectively. The Indian or the Asian cutoffs are slightly lower. We recently looked at this large database looking at the prevalence of sarcopenic obesity from an Indian setting, looking at the LASI database, looking at 72,000 people across India, and we find that sarcopenic obesity is present in about 9% of people. So yes, 1 out of 10 elderly people in our society have sarcopenic obesity. So how does this matter? How does this lead on to changes in clinical practice? How do we understand what is sarcopenic obesity and why does it happen? And then if you look at the pathogenesis, I would say it's a vicious cycle. So if I have a patient with obesity who has excessive fat, so yes, this excessive fat will be in ectopic sites, and muscle is definitely one of them. So again, if there is more fat in the muscle, that will interfere with good muscle function. So this patient would have poor muscle quality, poor muscle strength, and that would contribute to development of sarcopenia. If it contributes to sarcopenia, a sarcopenic individual would obviously find more difficult to do their routine physical activity. They will have muscle fatigue, disability. And once you start reducing the burnout of your calories, you start to put on weight, and thus that can lead on to obesity. So what we are saying is that sarcopenic obesity is a vicious cycle. One leads to the other leads to the first again. And definitely with the process of aging, this entire process is fast-tracked in patients who develop sarcopenic obesity. I'm not going to bore you with this complicated slide of how the pathogenesis of sarcopenic obesity, but I think what is really important for us as clinicians is to understand what is the impact of that in our patients. So several studies have shown that there is definitely higher frailty, more disability, more admissions that is seen in patients with sarcopenic obesity in this study. You look at the odds, all of them are significant. Not only this, our patients with sarcopenic obesity have a higher odds of knee arthritis, 350 times, 3.5 is the odds. And looking at osteoporosis as well, patients with sarcopenic obesity have a 3 times higher risk of developing osteoporosis. Obviously, this entire concept of muscle, bone, joint, they all go together. What about metabolic problems? And looking at metabolic syndrome, looking at diabetes, hypertension, and dyslipidemia, again, no exception, very strong figures of metabolic syndrome having an odds of 8 times higher risk in people with sarcopenic obesity. So this is something important. So is associated depression. But if there was one slide that I really wanted to highlight for all of us listeners today to listen, that sarcopenic obesity is associated with a significantly higher mortality. If you look at this slide carefully, it is the last graph, the dotted graph that tells us the mortality of people with sarcopenic obesity. It is much higher than people who have only obesity or only sarcopenia. So definitely this needs to be recognized in our clinical practice because this is something that is leading on to a lot of problems, but most important, it is leading on to premature mortality. This is something that we definitely don't want our patients to go through, which takes me to the third and the last aspect of my talk. How do we manage sarcopenic obesity? And I would say there are three broad pillars talking about sarcopenic obesity management: the diet, the exercise, and the medicines. Let's start with the exercise. And what is really recommended is not only the aerobic exercise, which is important, but the resistance training as well. Again, this is another original clinical trial, RCT, looking at what type of exercises help in improving sarcopenic obesity. It is not only the aerobic, the resistance exercise, which is something that is also very nicely mentioned in the RSSDI clinical practice guidelines from India, that talk about not only having 30 minutes of aerobic exercise, but also to include at least 15 minutes of resistance exercise in our patients. Well, what type of exercises can help in improve sarcopenic obesity? Chair exercises, resistance band exercises. I'm aware of a very nice study done from All India Institute, New Delhi, led by Dr. Naval Bikram, how they've used an elastic band to improve sarcopenia and sarcopenic obesity in young individuals with obesity. And that is something which is cheap and very effective in the Indian setting as well, right? The role of exercise, what is really important is not just the acute exercise, not telling that patient does 5 kilometers one day and does not walk the rest of the day. I think regularity is important. And obviously, a stepwise approach is important. We can't ask our patients to start doing all the aerobics and resistance on day one. We start gradually with flexibility enhancement, balance training, and then go up further. What about diet? And I think if there's one important point that I really need to highlight about diet, that is to improve the protein intake in our patients' diet, apart from obviously improving the calcium and the vitamin D nutrition, what is really, really recommended by most South Asian guidelines, including this paper she wrote about 5 years ago, where how we can improve the protein content of our diet, which is an important component for improving muscle mass. And this is something really tragic. This is data from our own clinic here in Vellore, where we look at that despite people attending the bariatric clinic with morbid obesity, and despite having, many, many more calories than what they want, they still don't meet up the protein requirement that they have to, even in people with morbid obesity. Talking about drugs, well, at this point in time, unfortunately, we do not have many drugs that can address sarcopenia, but a lot of them are in the pipeline. Definitely in people who've had a premature menopause or those who have men with androgen deficiency, yes, usage of sex steroids is definitely helpful, but there are a lot of drugs in the pipeline, right from myostatin inhibitors to oral grenal analogs, which are currently in phase 2 trials, which have shown significant improvement of muscle mass. And I'm sure in future we will have a few drugs as well. But till then, I would say the exercise and nutrition are the core treatment aspects of patients for management of sarcopenic obesity. So friends, to conclude, what we're talking today about is a confluence of high body fat and low muscle mass, something that is known as sarcopenic obesity. This is something which is common. Even data from India, in the study, we saw that it was about 9% of the elderly population in India has sarcopenic obesity. What we need to know is we need to screen these patients, and though there are very stringent criteria to diagnose sarcopenia, I think even simple tools can be used like SARCF questionnaire or scarf circumference to identify low muscle mass, and then we can look at the high body fat. Well, from a clinical aspect, these are something, this phenotype has a significant impact, not only in diabetes, hypertension, depression, osteoarthritis, but even more important, mortality is there, and depression is also described. And at this point, management of sarcopenia, though we talk of 3 broad pillars, I would say diet, having a better amount of protein, and including resistance exercise would be the key treatment strategy. So with this, I would stop, but I would be happy to take any questions.
Thank you, Dr. Nitin. That was an excellent talk on sarcopenic obesity. Usha ma'am, your comments.
Oh, what can you say about Nitin's talk? It was very comprehensive, covered everything, and highlighted the importance of how sarcopenia itself is a risk factor for so many of the other things that we associate with diabetes. So, and for some reason, Indian population is more prone to sarcopenia and sarcopenic obesity. We have known this for a long time about thin, fat, obese people in India, and I mean, it's kind of an extension of that. And we need to do so more to overcome sarcopenic obesity. Yeah.
So, Dr. Nitin, I'll request you to stay back for the discussions. With that, we move on to our next speaker, Dr. JK Sharma. Ma'am, would you like to introduce it?
Sure. Pleasure to introduce Dr. J.K. Sharma, and Medical Director of Central Delhi Diabetes Center, and has many multiple honors, honorary visiting professor, discipline of medicine at Mahatma Gandhi Institute of Science and Technology, Jaipur, Rajasthan, and has honorary professor of the IMA headquarters. Like I said, many honors, has held many important positions, and really looking forward to hearing from him about management of obesity and diabetes.
Thank you, Dr. Usha. Good evening to all. At the outset, I express my heartfelt thanks to Dr. Shalini and Dr. Rajiv Chawla for having asked me to speak on this very important topic of obesity and how to manage the obesity. And I would like to congratulate both of them for running the show exactly at the time. Very well managed. So can I share my screen?
Sure, sir.
Can you see my screen?
Yes, sir. It's just coming on. Yes, sir. Now we can see. You just need to put it in full screen mode.
Is it okay?
Yes, sir.
Just a second. So in the next 15 to 16 minutes,
sir, it's gone back full screen mode.
So I will talk about the medical management of obesity. And we all know when we talk of the evolution of man, from the Neanderthal man to Homo erectus to Homo sapiens, and now we have reached to a state of Homo obesiticus. The WHO says that more than 1 billion people worldwide are obese, 650 million adults, 340 million adolescents, and 39 million children. And by the year 2025, approximately 167 million people, adults and children, will become less healthy because they are overweight or obese. So it is a vast problem. We Asian Indian phenotypes, in spite of the lower BMI, South Asians have more abdominal fat. That is how they are the thin fat Indians. They have more insulin resistance and hyperinsulinemia, higher levels of C-reactive protein, lower levels of adiponectin, and the characteristic dyslipidemia, leading to increased susceptibility to type 2 diabetes and coronary artery disease. The very famous ICMR India National Cross-Sectional Study projected for metabolic disease prevalence in India, and we can see that the generalized obesity, 254 million of people, and abdominal obesity, 351 million of people, which is a huge number. Obesity, we all know that it leads to development of cardiovascular disease, type 2 diabetes, and the liver diseases. In a healthy person, when we give high-fat diet, there is fat accumulated in the adipose tissues, and there is low energy expenditure, and through these various adipokines, pro-inflammatory cytokines, and the mitogenic factors, it leads to insulin resistance, leptin resistance, lipotoxicity, dyslipidemia, fibrogenesis, pancreatic beta cell deficiency, and they all lead to obesity with associated diseases, the malignant tumors, cardiovascular diseases, type 2 diabetes, and liver diseases. So how to manage? The current management strategies goes to dietary advice, physical activity, that is lifestyle, behavioral therapy, education to the patient, then comes the pharmacotherapy, and if it is not even by control and managed by this, then we go for the bariatric surgery. Now, regarding the diet, physical activity, and the behavioral therapy, it is designed to achieve more than 5% weight loss that should be prescribed for overweight and obese patients with type 2 diabetes ready to achieve the weight loss. And Intervention should be high intensity, more than 16 sessions in 6 months, and focus on diet, physical activity, and behavioral strategies to achieve a 500 to 750 kilocalorie per day energy deficit. If you go for 3 months, that is the short-term intervention that employ very low calorie diet, that is less than 800 or 800 kilocalories per day. And the total meal replacement may be prescribed for select patients by trained practitioners with close medical monitoring to maintain the weight loss. Such program must incorporate long-term comprehensive weight management counseling. And this is as per the ADA standard of medical care published in 2017. Now, when to start the pharmacotherapy in obesity management? The first step is the lifestyle modifications. And if there is no desirable weight loss for 3 to 6 months, and on the other side, if the BMI of the person is 30 or more, or BMI of 27 or more, with 2 or more comorbidities like hypertension, diabetes, pre-diabetes, and dyslipidemia. We all know that we have equal number of pre-diabetic patients or even more than the diabetic patients in our population. In that case, start with the pharmacotherapy in addition to lifestyle modifications. The consensus statement for diagnosis of obesity, abdominal obesity, and the metabolic syndrome for Asian Indians, and this was given in the year 2009, and I don't think there is any consensus from we Indians after this in last 14 years regarding this obesity, abdominal obesity, and the metabolic syndrome. And this consensus, which was in 2008, this says that the BMI cutoff for Asians, normal BMI 18 to 22.9 kilogram per meter square, overweight is 23 kilogram per meter square, and obese is 25 kilogram per meter square. So earlier it was 25 for the above 25 for overweight, but now it is 25 kg, means it is obese. And the treatment according to the BMI category, if you look here, the international and the Asian 25 to 26.9, but in we Asian Indians 23 plus, 25 plus, 27. So diet, exercise, behavior remains in all the 5 categories. Pharmacotherapy comes here from 25 plus with comorbidities, or 27 plus or 32.5 plus or 37.5 plus. And then bariatric surgery role comes with comorbidities at 32.5 plus. Now coming to the concern about using the anti-obesity agents due to safety issues with past agents, we all know that the various agents came and they have gone because of the various safety concerns. So structured obesity management is step therapy, and then the therapeutic lifestyle change combined with any treatment modality enhances weight loss, energy deficient meal plan, increased physical activity, behavioral modification, and medical management of the obesity. Various pharmacotherapy, we all know that drugs like lorcaserin, rimonabant, then fenfluramine, sibutramine, dexfenfluramine, they all came, but they all have gone because of their side effects. So now what are the anti-obesity medications we have as on today? And the site of these various FDA-approved anti-obesity medications, they are at the level of the brain, at the level of the intestine, pancreas, stomach, and at the adipose tissues. And various medications have the site of actions either central site or at the peripheral site of actions. Now, the profile of weight loss medications, the AACE, American Association of Clinical Endocrinology 223, they have given that this is a very busy slide with semaglutide, liraglutide, phentermine, topiramate, the combination, then naltrexone and bupropion, then orlistat. So all these various types of combinations have been given, and this is what has been given by the ACE. But we look at the 5 FDA-approved medications for medical management as an adjunct to lifestyle modification: the orlistat, phentermine topiramate combination, then bupropion, naltrexone combination, liraglutide, and then the semaglutide. And the further categorized by their approved length of use, like the short term, generally 12 weeks or less, and long term or the chronic use. Pregnancy always remains the common contraindication to all these medications. Now, orlistat is available in India The liraglutide 3 milligram is not available. Lorcaserin has already been withdrawn, as I told you, and then the semaglutide, which is approved 2.4 milligram, approved once a week in US, but it is yet not available in our country. There are 4 broad categories: peripheral acting agents reducing the efficiency of digestion, then agents modifying the homeostatic regulation of food intake and the energy expenditure, and they again have central action and the peripheral action, as I earlier told you, and the agents that inhibit the food intake by acting on the brain's reward centers. So peripherally acting agents reducing the efficiency of digestion, we take the first, that is the orlistate. This is the anti-obesity drug available as on today in our country, gastric and pancreatic lipase inhibitor. It blocks the intestinal action of lipases on the ingested fat, decreases the fat absorption by 30%, and non-absorbed fat excreted through the rectum as oily discharge, greasy stools, oily spotting, liquid stools, fecal urgency and incontinence, flatulence and abdominal cramping, and certain people, certain patients does not like all these things. Reduced absorption of fat soluble vitamins is also one of the side effects of this drug. But if you look at the long-term change in the body weight, if you see here 1 year and 4 years, in 1 year it was 10.6 kgs, and in 4 years it was 5.8 with as compared to the placebo. Now, I have already told you about this lipase inhibitor, common side effects. The practical tips are GI side effects subside after the first couple of months. So this we have to explain to our patient, and we supplement with the fat soluble vitamins. The dose is 60 milligram to 120 milligram 3 times a day with meals that contain fat, and decrease the rate of progression to type 2 diabetes, reduce the number of anti-hyperglycemic medications taken by patients with diabetes, and improve the glycemic and the lipid control. Now, the phentermine is the short-term use. It increases the energy expenditure and appetite suppression. Weight loss is 3.6 kg in 2 to 24 weeks. Common side effects are palpitation, tachycardia, increased blood pressure, insomnia, dry mouth, and overstimulation. And so it is not recommended in patients with hypertension, with CVD, hypothyroidism, history of drug abuse, and pregnancy. In pregnancy, there is a definite contraindication. Generally administered 15 to 37.5 milligram once a day before the breakfast, and it remains the most widely prescribed weight management therapy, usually prescribed for long-term use despite FDA approval for short-term use only and lack of long-term data from the clinical trials. Then the combination of phentermine and topiramate, it suppresses appetite, improves satiety, increases energy expenditure. Again, we can see that 6.6 to 8.6 kg per year weight loss is there. And after 14 days, it can be further into the highest possible dose of 7.5 and 46 milligram combinations. Then the naltrexone and bupropion combination therapy for the long-term use, it suppresses the appetite and 4.9 kg weight loss in 1 year. Titration schedule starting with 1 tablet, 90 milligram, initially week 1, then increases by 1 tablet each subsequent week, and it improves in high density lipoprotein, TZs, glucose, and insulin were noted with this combination of the effect. Now we come to very important, the GLP-1 effect in the humans, which we all know about that. It acts at the brain, at the pancreas, pancreatic beta cells, and the stomach. Then effect on the gastrointestinal and the central nervous system, we see that decreased gastric emptying and decreased acid secretion. There is increased satiety signals at the level of the brain and decreased energy intake. Now, here we looked at the brain level, there is decreased appetite, increased energy expenditure, decreased heart rate, and increased myocardial contractility. Adipose tissue, increased lipolysis, glucose uptake, hepatic glucose production is decreased, increased insulin secretion, beta cell proliferation has also been mentioned, and increased glycogen synthesis, glucose oxidation. So these are the various effects of the GLP-1 agonist. Certain contraindications like multiple endocrine neoplasia, MENS type 2, person or family history of medullary thyroid carcinoma. Consider if there is a history of pancreatitis and if there is gastroparesis. Adverse events, patient education. Common adverse events are nausea, vomiting, constipation, dyspepsia, hypoglycemia, and abdominal pain, and rarely pancreatitis and gallbladder disease. Benefit in patients with diabetes or pre-diabetes. In pre-diabetes, it is the off-label use, and patient education is regarding the mindful eating is important. And these adverse events has been seen that after a certain time, once we start the medications, they go away. Liraglutide long-term use suppresses appetite and improves the satiety. 5.8 kg in 1 year. Again, the common side effect, monitor heart rate, renal function, behavior changes, blood glucose in patients with diabetes, and may need adjustment with other anti-hyperglycemic agents. Now come to oral semaglutide, the first and the only oral GLP-1 available. 80% of the patients achieved HbA1c less than 7%. We see here the baseline HbA1c, if it is more than 8%, 1.5% decrease in HbA1c. If it is more than 9%, it is more than 2.6%. And look here, the weight from 94 kg, it has less decrease, 5 kg weight loss is there with this drug. And the composite endpoint, if you look at achieving both 1% HbA1c and 5% weight reduction in all these pioneer 1, 2, 3, 4, 5, 6, 5.8, because of the paucity of time, I won't be going in detail about all these. But the post-hoc analysis with oral semaglutide 14 milligram, higher proportion of patients achieved HbA1c reduction of more than 1% and weight loss of more than 5% compared to placebo and the comparators. Now, multifactorial benefits with the oral semaglutide, HbA1c, weight, systolic blood pressure, lipid parameters, and the waist circumference. And this is the mean percent weight change reported in the main phase 3 extension trial of the FDA-approved anti-obesity management. This is again algorithm for the selection of anti-obesity medications, depending on the age, depending on the comorbidities. And then we can choose from these various different molecules available with this. Then a word about twin cretins, dual GLP-1 and GIP receptor agonist. Tirzepatide key trial intermediate outcomes. If you look here, the change from baseline HbA1c, change in body weight, change in LDL, change in systolic blood pressure, and quality of the life. SURPASS-2 trial, 40-week open-label study that evaluated the tirzepatide in around 1,800 adult patients with inadequately controlled type 2 diabetes. While on metformin at week 40, all tirzepatide doses were superior to semaglutide based on the mean change in HbA1c. And we can see here that more patients who received tirzepatide compared to semaglutide achieved an HbA1c of less than 7%. Estimated treatment difference at 40 weeks, weight 5.5 kgs, LDL 1.2 milligram, and systolic blood pressure by around 3 millimeters of mercury. Now, the late-breaking weight loss innovation, new drug therapy shown to offer positive outcome for obesity and type 2 management. There are various other drugs. The orofenadrine, then CagriSema, oral semaglutide 50 milligrams shows 17.8% weight loss. Survodutide shows nearly 19%. Tirzepatide 15 milligram. Then retatrutide shows 24.2% weight loss. So to conclude with these new drugs in development, anti-obesity therapy have potential to vastly expand, allowing better treatment options and personalized approach to obesity care. And with more and more agents that may be made available, pharmacotherapy will be an important adjunct to lifestyle modification in the near future. Customization of anti-obesity treatment may soon become a reality. Few die of hunger, many die of eating. This has been said by Benjamin Franklin. And with that, I thank you, everyone. Thank you, and I finish here.
Thank you so much, JK sir. That was a very comprehensive overview of medical management of obesity, and I think you touched upon everything right from orlistat to the current drugs that are available. We'll request everyone to stand by for the questions after the next session. Thank you so much, sir. We now move on to our next session on cardiovascular risk management in diabetes by Dr. Dheeraj Kapoor. We all know him well. He is an endocrinologist at Artemis Hospital, the chief of endocrinology at Artemis Gurugram. He's got around 70 publications to his credit. He's the editor of monograph on emergencies in diabetes endocrinology, injectable therapies in diabetes, as well as editor of the book Diabetes in Pregnancy, a comprehensive approach. He's been on the advisory board of numerous journals, as you can see here, and a faculty well-traveled in national, regional, as well as international conferences. Dr. Dheeraj, please.
Well, thank you so much, Dr. Shalini Jaggi. And are my slides visible?
Yes, sir.
Thank you so much, Dr. Chavla sir and Dr. Shalini Jaggi, for inviting me here. You know what? That high sugars do not kill anyone. Cardiac disease does. And in fact, that is the primary cause for mortality in type 2 diabetes. So as we can see that cardiovascular disease does not spare any gender. Men and women carry approximately the same risk. However, women without diabetes are, shall I say, protected till menopause. But if someone turns diabetic, that gender advantage is lost. So it is the leading cause of death in people more than 65 years of age. The ticking clock hypothesis that we talk about. So because of insulin resistance, possibly, there's an early endothelial dysfunction and vascular inflammation. There's recruitment of monocytes. Fatty streaks develop. In fact, they have been found in children as young as 3 years old. And if uncontrolled, if the lifestyle modifications don't happen in time, you have atherosclerosis. Someday the plaque will rupture, occlusive thrombus, and a cardiac event ensues. So cardiac management is not about glycemic control alone. There are a majority of factors that one should see. The ABC, which is the HbA1c, the blood pressure, and the cholesterol. Ideally, HbA1c below 7, BP 130/80, and LDL less than 100. So 2.6 times 38, that's the conversion factor that we are talking about. The HbA1c has not improved in the past so many decades, possibly going a yo-yo way. So I'll jump the ESC guidelines. ACC and AHA are more simple to understand. So HbA1c more than 6.5, but less than 7, consistent with type 2 diabetes. Lifestyle modification is the first and the foremost thing, which means exercise more than 150 minutes per week. But we, Southeast Asians, small frame people, which means smaller pancreas, more visceral fat, which means higher load of insulin resistance, I would feel that around 300 minutes per week would be more appropriate for our class of population. And of course, severe risk factors may be cholesterol, blood pressure, platelet aggregation. All of them need to be managed aggressively. Now, interestingly, the diabetes societies say metformin is the first line, although ESC has said gliflozins or GLP-1s. I would not wish to enter into that debate, but ADA still maintains metformin as the first line, provided there are no contraindications. So if HbA1c less than 7, fair enough. If it's on metformin, continue metformin, but you must reinforce diet control and exercise lest the patient gets complacent. If they are not in place on metformin, then gliflozins and GLP-1s are the way to go. And if still not controlled, then obviously you would wish to add another OAD or an OHA, as the case may be, based upon patient profile. So now type 2 diabetes, again, so the cardiac societies say that ASCVD, star gliflozin or GLP, even ahead of metformin. And if then you aren't at target, then add metformin. If someone is not a high CV risk or an established CVD, you can start metformin and then follow the algorithm and keep on modifying the therapies based on patient profile. So the bottom line is that gliflozins and GLP-1s are the recommended first-line drugs in drug-naive patients who have a high ASCVD. So lifestyle modification has to be started, and that, of course, goes unsaid. Glucose control, BP control, control of lipids, weight management, and anti-platelet therapy. At this juncture, I would wish to mention that in the process of controlling sugars, if you put on a weight of 3 kilograms, you actually negate the advantage ensued by 1% fall in HbA1c. So goals, as I said, and I repeat here as well, just to reinforce, HbA1c less than 7%, physical activity more than 300 minutes per week in our kind of a setup and population, blood pressure less than 130 by 80. Very high risk, less than 55 is the LDL we aim at, and even the LAI has come out with its guidelines. So taking these issues one by one, lifestyle modification. First of all, stop smoking. That goes unsaid. Weight. So weight reduction in patients with IGT so that they don't progress to diabetes. Mind you, the CV risk starts from the process of IGT, what we call the ticking clock hypothesis. Then aim for weight stabilization in patients with diabetes, or possibly start agents which would help them lose weight, like the gliflozins and the GLP-1s. And if the person does not lose 5% of his existent weight in 3 months, then you have to replan your strategy to achieve more weight loss. Now, this is the ESC guideline for dietary targets, but I would still stand by the ADA, which means total fat intake less than 30%, saturated fat less than 7%, dietary intake of fiber more than 35 grams. That's what I would still stand by. So lifestyle modification in its own right reduced CV mortality and morbidity by 41% in the Darking study as compared to controls. Well, the intervention group was either diet alone or exercise or a combination. And needless to say, it was the combination that fared the best. Now, lipid-lowering agents, well, they can be given either as a high intensity or moderate intensity. High is rosuvastatin 20 to 40 or atorvastatin 40 to 80. And just half of this would be the moderate intensity. So you have to figure out how much cholesterol do you want to fall. If it's more than 50% decline that you want, you would wish to start on a high intensity therapy. So management as per the ADA, because I would not wish to confuse matters, it says 40 to 75 without additional risk factors, LDL, moderate therapy has to be there. So I think between 40 and 75, most of our patients should be receiving a statin therapy. Those who have additional risk factors start with a high therapy, and below 40 or above 75, take your call whether they actually need to have it or not. Triglycerides, well, there is data to show that Indians do have small dense LDL, and HDL molecules are also smaller, which means that small dense LDL are more atherogenic, small dense LDL are more resistant to degradation. Smaller HDL particles are easily degraded, which means you have a spoiled LDL-HDL ratio and a high risk of CVD. But still, the guidelines do say that above 500, if features are there, only then you should aim for pharmacological management. And it goes without saying that you have to start lifestyle even at lower levels. Levels more than 1,000 obviously carry a huge risk of pancreatitis as well. So lifestyle intervention, 40 to 75, most patients should receive. Below 40, above 75, the patient profile has to be considered. So BP target, well, again, I would go by the EASD guidelines, which say 140. ADA also says 140, but there are some suggestions of 130 by 80 by the Cardiology Society guidelines. But I think we do follow the ADA, and that's what we should be doing just to avoid confusion in the minds of the patient and the treating practitioners alike. So lifestyle interventions, weight loss, sodium restrictions. Now, sodium restriction in our society would mean less of pickles, less of chutneys, less of papers. Obviously, no salt should be added on salads or with yogurt. Processed food, anyways, should be minimized, both to have a good glycemic control and less sodium. Now, here I would like to mention that the low sodium salt should be avoided in patients with renal insufficiency because it contains high potassium. So in certain subsets, low sodium salt may be helpful, but not so much in the CRF patients. In fact, it could be detrimental also. BP, well, I'll come to the algorithm in the next slide. There we are. So if it's between 140, it should be below 140. Between 140 and 160 is systolic. Start with a single agent. Could be any. However, if there's albuminuria, then ARBs and ACE inhibitors are best started. And if the BP is still not controlled, then you go on escalating as per the CCBs or diuretic. If BP is more than 160 by 100, start 2 agents. If you have albuminuria, ACE or ARBs has to be one of them, and the other as per the patient profile and your discretion. Treatment well tolerated, therapy to be continued. If not meeting targets still on 2 agents, go on to the third. Hypertension is a risk factor for CVD with or without diabetes alike. Obviously, men with diabetes have a higher mortality. So as the cholesterol levels rise, the mortality rises. Now, as regards aspirin, well, secondary prevention, it has to be given. Primary prevention role is debated, but now the suggestions are that if the patient is a high risk for ASCVD, you may even start aspirin for primary prevention. Again, to your right is the ADA. Consider aspirin therapy 75 to 162 for primary prevention in those with type 1 diabetes or type 2. So even type 1 diabetes carries a high CV risk for a variety of reasons. I do not wish to go there because more than 90 or 95% people are type 2. So that is the primary focus here. But nonetheless, both of them carry a huge risk. And in those with secondary prevention, you must start aspirin therapy. Now, if someone has sustained an ACS, then it's obviously prudent to start with 2 agents and maintain them at least for a year. So glycemic control, HbA1c generally 7% or less, 6.5 to 9 would be very good. And higher the HbA1c, there's a higher risk of fatal and non-fatal MI, stroke, amputation, heart failure. Now, taking a slight detour, one must understand that if someone has a peripheral vascular disease, it is a dictum that always rule out cardiovascular disease. So glycemic control, well, ADA says metformin, unless, of course, there's a contraindication, which generally is either the liver enzymes more than 3 times normal or a GFR of less than 45. So if the GFR is less than 45, you don't start metformin. If someone is on metformin, continue. But then GFR below 30, metformin is best avoided. So UK-PDS, obviously, we know that no talk in diabetes can be complete without the UK-PDS. Conventional therapy and sulfonylurea insulin, there was benefit, but metformin accrued much more benefit even as compared to sulfonylurea and insulin, possibly because at that time we just had glibenclamide, which we know affects the heart adversely due to a variety of mechanisms. So the glucocentric approach, I'm afraid, is still followed by a majority of clinicians, particularly in the tier 2 and tier 3 cities. But then we come to the glucocentric approach. Now, the cardioglucocentric, which means that protect the heart. See, mind you, as of now, most drugs in the scenario do not affect the adverse events on the heart. However, they're cardiac friendly, not cardiac protective. Now, we are in an era of cardioprotective drugs with the advent of gliflozins and the GLP-1s. And now, with diabetic drugs causing weight loss, we are having the adipocentric effect, which means reduce the resistance, the vaspins, the TNFs, the interleukins, and reduce resistance, and therefore have beneficial heart on the blood vessels and the heart. So AD standard of care, we are all aware of it. ESC, I will not deal into because it will only add to confusion and for paucity of time as well. But CV benefits, leader trial came with a bang, 13% reduction in MACE and CV mortality. And CV safety was there in the Pioneer trial, the Alexand XL. However, superiority with liraglutide, semaglutide, dulaglutide, so on and so forth. So GLP-1s have proven superiority. Now, how do they act? Well, at the cardiac level, they decrease inflammation, increase glucose uptake, decrease ischemic injury, and at the level of the blood vessels, stabilize the plaque, increase the blood flow, reduce inflammation, improve endothelial dysfunction. At the renal level, increase natriuresis and diuresis. They inhibit platelet aggregation. At the intestinal level, reduce postprandial glucose and therefore prevent postprandial hypertriglyceridemia and reduce inflammation at the level of adipose tissue. And obviously, it goes without saying that they reduce the appetite at the brain level. So variety of those. Effect on MACE is positive. As regards gliflozins, well, they have virtually changed the way we manage diabetes. EMPA-REG was the first to come. Heart failure reduction, 38%. And of course, the MACE was also reduced. Declared TIMI, unfortunately, could not achieve that, but one must understand that in Declared TIMI, those with established CVD actually had benefit, while 40% patients had a high risk for CVD, but had not sustained the event. Those were the ones who weren't benefited much, but dapagliflozin showed benefit in those who had already had a cardiac event. So mechanisms, well, mechanisms, so many of them: reduce blood pressure, diuresis, natriuresis, dilation of blood vessels, and ketogenesis. Ketones are a very good fuel for the failing heart. Of course, they reduce the LV mass, so on and so forth. So these are the drugs. Now, which of the two? Well, it is entirely your choice. And I will just compare these two. I'll just jump these busy slides. We are all aware. I'll just compare GLP-1s and SGLT2. First of all, the number needed to treat to prevent the event: GLP-1 75, gliflozins 97. So GLP-1s are both oral and injectable. Gliflozins only oral. GLP-1s reduce appetite. Gliflozins don't. You need to monitor GFR with gliflozins below 25, generally not. There are studies with 15 mils of GFR as well. CV benefits, well, both. ASCVD primarily GLP, gliflozins heart failure. GLP possibly increase the heart rate by 1 or 2 pulses or beats per minute. That in the borderline patient may precipitate heart failure, but still it is debatable. Gliflozins are fast-acting. GLP may not be. The risk of the GTIs is higher with gliflozins. We have published a paper in IgM where we've shown 23% increase in GTI. Hypos don't happen. That's the benefit. GI adverse events more with GLP-1s. One has to be cautious about medullary thyroid carcinoma, family history before giving this. This drug, GLP-1, should not be given to patients with history of pancreatitis. Should not be given. So guidelines suggest that if patient is a high risk of CVD, possibly you could give GLP or gliflozins ahead of metformin, although our ADA still says it's got to be metformin. So to summarize my talk, you have to consider the patient presentation, evaluate, diagnose, and then treat. Many factors contribute to increased CV risk in type 2 diabetes. Lifestyle modification is the cornerstone, which on which treatment is based: glycemic control, blood pressure control, dyslipidemia management, and platelet. It has to be a holistic approach rather than a glucose-centric approach. Metformin, as per ADA, but as the second line, one should use the drugs which have cardiovascular benefits. Cardiovascular friendliness might not be sufficient alone. Thank you so much for your attention.
Thank you, Dr. Dheeraj, for that excellent deliberation. And now the house is open for discussion. Dr. Usha, ma'am, are you there?
I'm here.
Yeah, so maybe you can just have a few discussion points, while I'll just look out for questions.
Yeah, I'm just saying that all the four speakers covered the topic of obesity, from redefining it to sarcopenia to medical management, and then the all-important, CV risk. It's been covered thoroughly. If there is any audience questions, we can take that. Or if any of the, speakers have questions for the other speakers, this is a time that we could also use for that.
Is Dr. Nitin still there? Dr. Neeta, are you there?
Yes, I'm there.
I saw her.
So maybe I can ask you this question. Dr. Nitin was talking about sarcopenic obesity, and we've heard an excellent lecture from Dr. J.K. Sharma on the different pharmacotherapies when it comes to obesity management.
Yeah.
So, we've been using a lot of SGLT2 inhibitors, not only for diabetes, but all the pleiotropic benefits, and obesity also happens to be one of them. This brings me to the question of losing weight in terms of fat plus lean muscle loss, because we see a lot of patients on SGLT2 inhibitors for a long time coming back and saying, my legs are becoming thinner, and, they're not really doing all these stretching and these strengthening exercises. So what is your take on the pharmacotherapy part of drugs used for weight loss? Do we actually consider sarcopenia? And,
sorry, so the question is that you're asking about pharmacotherapy and sarcopenia, right?
Yes.
Yeah.
I mean, losing weight through an SGLT2 inhibitor and losing the muscle mass as well. So aren't we like, isn't it this a paradox?
Yeah, so it is a paradox, but this can be mitigated by a proper program. So when you give GLP-1 receptor, or if you give SGLT2, you have to make sure that it is part of a proper program and not just a prescription. So unless it's part of a regular program where these things are monitored, ideally speaking, when you're actually wanting weight loss, looking at hand grip as a measure of sarcopenia, or if somebody has a bioelectrical impedance machine to look at the fat mass and all of those things. So it is a comprehensive thing. So giving a GLP-1 receptor agonist just for weight loss without monitoring how much protein the patient is eating, without knowing whether the patient is doing strength training or not, without looking at the assessment of sarcopenia, I think it can actually be a double-edged sword. You're very right in saying that we need to take care of all these things when you are giving such drugs for weight loss.
Dr. Neeta, Dr. Shalini is asking about SGLT2 inhibitors in particular.
Yeah, even when you're giving, whether you're giving SGLT2 inhibitors or you're giving GLP-1, my answer would be the same, that if somebody is losing weight, please do the assessment and make sure that lean muscle mass is not being lost, and take care of it, is what I would say.
But
So
Dr. Neeta, with SGLT2 versus GLP-1, GLP you don't tend to lose any lean muscle. And
no, if the weight loss is very high, you can.
Of course, but with SGLT2, at least you lose 1/3 of your muscle mass until unless you are doing resistance exercises and you are in a very well structured program.
That is exactly what I emphasized.
Yeah.
So any kind of weight loss, when it starts to happen, it has to be part of a program and it has to be assessed.
Yeah.
And it has to be taken care of with the help of weight training exercises and looking at how much is being lost.
there is no point losing muscle mass and developing more
Absolutely.
sarcopenic obesity, rather
Absolutely.
increasing overall risk for fractures and for overall
Very
CVD
right.
also. Yeah. So
So I
Absolutely
think,
correct. Yeah.
yes, so
very,
I
very
think
conscious.
exercise as well as MNT and a clear assessment of their nutrition is a very important part of
Very
any
important
obesity
aspect.
program.
Yeah.
Simply writing a drug, putting him maybe on a GLP-1 or maybe an
Yeah.
SGLT does not really do the trick, and never promise the moon to your patient when it
Yeah.
comes to pharmacotherapy, because many a
Yeah.
times, we've had patients wherein we kind of tell them that this GLP is the wonder drug and you'll lose like 30 kgs and it's as good
Yeah.
as a
Yeah.
bariatric surgery, without really talking about the entire comprehensive program that the patient
Program.
needs to be in. I think that is most important.
Yes.
Um,
Yes.
Dr. JK sir, if I can ask you this question, the role of orlistat. I mean, how effective is orlistat in an obese patient? Because in terms of weight loss, especially when we know that this obese patient is not really on a high fat diet, he's already struggling with weight, he's already on a high fiber, high protein kind of a diet. So does orlistat still work in those kind of patients? How much is the weight loss that we generally see with these agents?
Yes, that's right. But the mechanism of action, if we look, is through the weight loss, through the stool, through the feces. So if the patient is already on a low-fat diet, high-protein, low-fat diet, then it will not be that effective. And once you increase the dose to 60 milligram 3 times a day, it is cost effectiveness. If you look at then, that is also not so. Only people who have a high fat diet, then it is effective. Otherwise, for a long term, I don't think it is very effective.
Can I just
Sure,
answer
ma'am.
that as well,
Yes.
Shalini?
Yes, ma'am, sure.
Yeah, we have some data coming up where even on a low calorie diet and even when we are looking at the fats and all that, orlistat has given very good response, especially at slightly lower BMIs. So that data is yet to come, but then yes, we have revisited orlistat and we have found that it is actually not a bad alternative, especially in lower BMIs.
So does it work even
It
when patient
works.
is not really
It
on a high fat? I mean, is
yes,
it orlistat alone with MNT and lifestyle, or is it an additional
no,
pharmacotherapy?
it is orlistat with lifestyle and MNT.
And what doses, ma'am, if I may ask you, actually?
120.
Okay.
Yeah, and it's at 120 3 times a day. It
Yeah,
has
because
really worked.
we're just seeing a resurgence of orlistat coming in, so I wanted to ask
Yes,
this question,
yes, yes. It's been
because
working.
right.
Yeah, yeah.
So any particular, so how do you know? Okay, this is a general question for everyone. When you put a patient on something like a GLP, and you're actually focusing on weight loss, when do you know that the patient is a non-responder in terms of weight loss?
I don't think we need to give more than a couple of months.
Yeah,
A
no,
month.
actually, yeah, if in 3 months there is not even a 5% weight loss, then we would consider them as non-responders.
Absolutely. So that's a very
Cutoff
important
is that you need to have at least 5%
5%
weight
weight
loss,
loss.
maybe over 3 to 6 months. If it
Yes.
is less than 5%, that means it is not work and it is not working as an anti-obesity drug. Of course, glycemic benefits, everything will come, but you need to have at least 5% weight loss over 6 months' time.
So this, orlistat, rather being blunt here, we've always believed to be a very dignified kind of a placebo. But, this, and at 120. But this new data emerging could have interesting implications because, you know what, once we ask a patient to, do diet control, fat is the first thing we ask him to stop. Not boiled food though, but eliminate amounts. Now, if he's not having fats, what will orlistat do? But this, Dr. Neeta, is the new data she's suggesting could have interesting implications.
Do we have any more questions? Just check. So Dr. Usha ma'am, anything that you would want to discuss here? We have our panel here.
No, I think she's left the meeting.
Oh, okay. So Neeta ma'am, your take home for all healthcare practitioners who actually, what exactly should they keep in mind whenever they're thinking of starting any pharmacotherapeutic agent for a patient with obesity?
Yeah, before starting any pharmacotherapy, one, whether they fit into the criteria, then you have to look at all the contraindications first of all, and ease them slowly into it, and the willingness to go for pharmacotherapy. If they're not, then you have to counsel them. But my take home message is, do not delay pharmacotherapy, because lifestyle modification will have only that much to offer. And if you do only caloric restriction to a large extent, then hormonal imbalance is going to happen in terms of ghrelin and endogenous GLP-1, and there is going to be a relapse. So pharmacotherapy is here to stay, and we should not resist it and use it appropriately when it has to be. It's just like insulin. If you defer insulin for too long, what happens to a diabetic? In the same way, an obese person becomes a chronic obese person if you do not institute pharmacotherapy. Of course, it's very early days yet to say whether it is a permanent thing or whether you can wean them off. That only time will tell. It's too early to say. And I'm of the opinion that yes, we can try to wean off, but we should not resist pharmacotherapy is what I'm saying.
And the answer to the question that is often asked when a patient is on a GLP, for how long should I continue? And now that now that I've lost weight, can I stop it?
Yeah. So if you have a absolutely perfect weaning off program, then it should be good. And I do not have any data to kind of substantiate this. But my gut feeling tells me that such patients who really want to go off GLP-1, you can wean them off with Orlistat. That is my personal opinion. I don't have data to back it. But some kind of pharmacotherapy, if it is going on, I feel that maintenance will be good.
Could I make a comment, please?
Sure, sir.
Sorry, I didn't mean to do this, but the data on stopping GLP-1 is available. And the most troublesome part of it is not the weight gain as much as the fact that the CRP, which is a measure of inflammation, goes up very rapidly in the first 6 months. And so therefore, you are putting some people with even subclinical cardiac or cardiovascular dysfunction at risk. My recommendation, and this has got I have no evidence for this whatsoever, is that if you're going to stop a GLP-1, I would highly recommend that you make sure that you have a high enough dose of a good statin on a DPP-4, which is weight neutral, but might be able to help them, not allow them to gain that much weight. I have no doubt.
So with this, we move on to our next symposium.
Thank you.
Thank you.
Thank you so much.
Thank you. Thank you. University of South Wales.
Thank you, Dr.
Mahima, are we uploading slides, Neelam or Mahima, or
Alex, please upload sir slides. Neelam?
No, ma'am, we don't receive any.
Sir, you'll have to do yourself.
Okay, I'll try to share screen. Sorry. Let me try to put it on first. Yeah, I found it finally. So if I can share my screen, I'll be able to show it to you. Finally, can you see it?
Yes, it's uploading.
So let's just put it on. Let's start from
slideshow mode.
Slideshow, yeah, it's hidden. So it's a totally different topic, and when Shalini and Dr. Chawla asked me to speak upon it in a diabetes conference, I asked myself, how can I hijack it to an endocrine topic? So it's a very simplistic kind of presentation. It's meant for a live audience. So I have a brief quiz, 3 or 4 questions. I've got a clinical scenario, which is based on a patient under my follow-up, and a very simple, brief take-home message. So if I was facing this audience in Delhi at the moment, I would have been very lucky. One, it being my place of growing up, my place where I spent 9 best years of my life, from my graduation in Maulana Azad and post-graduation in Safdarjung. So I would have asked you a very simple question about which of the following is the most important hormone, sans which life ceases to exist. Don't worry, I'm not going to ask such simple questions, which you'll say, oh, we are supposed to be postgraduate. We are looking for highly specialized answer. Cortisol is the answer, but this is just a tester question, just to see if the mics are working and you get used to what I've in store. Second question is a bit more relevance in clinical practice. How much cortisol is produced per day under physiological conditions? So knowing I don't have a live interaction with the audience, I'll just take a pause for a few seconds. So if you know the answer of this question, that how much cortisol is produced per day, it will be of immense help in clinical practice. So the correct answer is 9 to 10 milligram. It's around 6 to 7 milligram per meter square. So 9 to 10 milligram, C is the correct answer. The third question, which one of the following is recommended replacement dose for prednisolone in secondary adrenal insufficiency? A relatively easy answer. Secondary adrenal insufficiency means that there is something wrong with your pituitary and hypothalamic gland. So you're not producing enough CRH/ACTH, and then the cortisol is low. So, and we face this kind of thing post pituitary surgery. As I said, I'm more than happy for people to write down the answer. I think I'll refrain from answering it at the moment, but maybe I'll take it up at the end of the talk. So what is the recommended replacement dose for prednisolone in secondary adrenal insufficiency? Lastly, this is relevant. I'm sure you guys have been exposed to giving mega doses of steroids, especially dexamethasone, especially in COVID-19 pandemic. Now, if we are giving somebody equivalent to prednisolone of 5 milligram, which is, answering the question number 2, is the dose we use for secondary adrenal insufficiency. Which one of the following is correct equivalent dose for dexamethasone or hydrocortisone? So the whole relevance of this question is about when you're giving dexamethasone or hydrocortisone, you should be able to assess, am I giving this as a physiological replacement or is it a supraphysiological replacement? So if you go back to my question 1, physiological replacement dose for physiological production of cortisol is 9 to 10 milligram per day equivalent. In secondary agency, we give prednisolone equivalent to 5 milligram, 4 to 6 milligram. And what dose of dexamethasone is equivalent to prednisolone 5 milligram or hydrocortisone in that matter? The correct answer here is hydrocortisone of 20 milligram. For dexamethasone, it would have been 0.75 milligram. I'll explain to you at the very end of the talk what is the relevance of putting in these 3-4 questions which look very simplistic, and why I'm using or mentioning about cortisol in a talk related to diabetes. So nothing major about it. Adrenal glands perched on top of the kidneys, made up of 2 main layers, the cortex and the medulla. Cortex has 3 sublayers. The mnemonic I remember is the GFR, glomerulosa, fasciculata, and reticularis. It gets sweeter as we move deeper in the cortex. Glomerulosa controls the salt regulation in a gross way, if I speak. Fasciculata, the sugar, and reticularis involved in synthesis of androgen. So it gets sweeter as we move on within the cortex. So my talk is very brief. As I mentioned, it's only around 20 minutes. I've covered the first section. Let's go to the case presentation I've got. So I'm going back to around 5 years from this point. It was a ward round on a Thursday morning. I had a 62-year-old woman who was initially reviewed in acute medical unit, reviewed by the psychs also, because there was a very short history of change in personality. She was extremely restless. And the only objective sign which we noticed on examination was she was hypertensive. I vividly remembering going on the ward round, this 62-year-old who was previously fit and well came and stood next to me on the ward round. And the story from the husband was that she's just unstoppable at the moment. She had walked around 100,000 steps. I can assure you there is no extra zero here. 100,000 steps in one of the days. This is what husband told me on admission. So for most of us, doing 10,000 steps is the goal probably, but going 10 times that was quite a task. So how did this woman end up under the endocrinologist? So prior to the endocrinologist, she was reviewed by a psychiatrist who started her on antipsychotic medication. The combination of, this is not the picture for this woman. I've got her photograph with her permission in next slide. Although the BMI was normalish, this is not her, but as I said, she was around 28 kilogram per meter square. There was central obesity. Blood pressure was 160 by 94 millimeter of mercury, and there was facial appearance, which was a bit plethoric. The main reason she was referred to endocrine team was because of high blood pressure and low potassium levels. So endocrinologists get excited for secondary hypertension. Most of the time in clinical practice, we seek primary hyperaldosteronism, occasionally few chromocytomas / paragangliomas. And in this particular scenario, we were interested in finding out, is this hypertension and hypokalemia with metabolic alkalosis secondary to primary hyperaldosteronism, or based on the phenotypic profile, more related to excess cortisol production. So her urinary free cortisol were mega high. She was not suppressing on low dose DEXA suppression, and it was a ACTH driven process. So the source of ACTH we needed to find out. So after the provisional biochemical test, our diagnosis was it's an ACTH secreting tumor leading to a rapidly progressing Cushing's syndrome. Question was, where is the site of tumor? So just noticing the severity of the illness, we put her on block and replacement therapy comprising of metarapon and dexamethasone, and try to mitigate what risk factor or the complications which are associated with high cortisol. So the next set of investigation, we had her MRI pitch tree, which was normal. We carried out inferior petrosal sinus sampling. There was no central to peripheral gradient on AVS. On IPSS, the somatostatin scintigraphy scan was normal. Her whole body study was not picking up any obvious tumor or lesion. So we had a discussion in one of the MDTs and then arranged for a gallium PET for her. And this is her photograph with permission from the patient. This is how she looked. And initially when she presented, the BMI was around 28, but she started to put in weight in the next few weeks and months. And she had high blood glucose readings. She was not diabetic to begin with, but within few months we noted that blood glucose, despite being on metarapon and dexamethasone therapy, was creeping up. And thinning of scalp, element of skin pigmentation, probably driven by ACTH, and she developed full-blown signs of hypercortisolism, and her weight gain and mood swings continued. So we repeated a CT. We managed to notice that adrenal glands are getting larger based on ACTH drive. She had osteoporotic fractures, and the clinical condition kept on deteriorating. We managed to get her gallium PET, which identified a source of ACTH excretion in the pancreas. So if you recall, ACTH is produced by the pituitary gland. The only similarity with pancreas is it starts with a P. So it was a ectopic ACTH excreting pancreatic neuroendocrine tumor. We subsequently, she underwent a distal pancreatectomy and regional lymph node removal. And the histology confirmed what we suspected on clinical basis. So she had a well-differentiated neuroendocrine tumor, which was successfully resected. And the beauty of it was that although she had presented with weight gain, mood swings, high sugars, and had started to develop other stigmatas of Cushing syndrome, post-surgery on a follow-up, she looked a different woman. So learning point, what's the point of mentioning about this kind of condition? So hypercortisolism, as I said, can present with a change in mood and neuropsychiatric disturbance. In clinical practice, we probably have more patients with iatrogenic Cushing. And that was the whole point of telling you about how much cortisol is produced by the body in physiological states, 9 to 10 milligram, and how much equivalent of prednisolone or dexamethasone we need, even if we take out the pituitary gland. So Cushing's disease or syndrome is relatively rare. Probably pseudo-Cushing with secondary to obesity and iatrogenic because of inadvertent use of steroid is more common in clinical practice. In diabetes world, if you've got a type 2 diabetes patient with high degree of insulin resistance, it's worth considering this diagnosis. Ectopic ACTH excreting tumors are rare. They might present with rapidly progressive deterioration. So this is an ectopic ACTH excreting tumor, which we had identified as from a parotid gland as the primary. We had published it back in 2016. So as I said, the last section of my talk, I've got a simple take-home message for you. Remember the cortisol production under physiological state. Do think about, what is deemed as low dose of steroid, which can do to your vascular system, the bone, metabolism, everything. And in addition, the iatrogenic Cushing can in fact lead to adrenal suppression. So if you are using steroids for any other condition, be aware that it can lead to a adrenal suppression also. So to reduce my own cortisol level, I do something. I have been running for last 12, 13 years, and I've got another race lined up next Sunday. Thank you. As I said, I'm done with Dr. Chawla. If there is any question, I kept it very
wonderful. I think it was really wonderful, very unique case, and we hardly see such cases in practice of diabetology. Well, core endocrinologist people, I'm sure they must be seeing many more cases. So, do we have some comments from Professor Adi Mehta? It's a very, very simple way you have alluded to a wonderful presentation of Cushing syndrome, that too an ACTH producing tumor sitting in pancreas, which is a very, very unusual sight.
I agree with you. This was an absolutely fascinating discussion and was perfectly well done. I guess in practice, and again, this is a difference, I guess, in practice. Once that ACTH level is that high and the cortisol level is that high, I'm not sure that I would do further pituitary testing. I think you're looking for an ectopic almost immediately. It is very, very unusual to find an ACTH level of over 150 or 200 from a pituitary. And so I would probably not have done the petrosa sinus sampling. I would probably gone straight to looking at something. And by the way, he did the CT scan, which is fantastic. I would have done the CT scan, and it would be a stretch to do an MRI as the first technique. But this was fascinating, and I must admit this is great. Thank you very much.
Wonderful.
Thank you, Prof. Eddie. We carried out everything simultaneously. It was easier for us to get a MRI PET, CT, abdo, TAP, the whole thorax, abdo, and pelvis, MRI adrenals, not adrenal, but we did for the whole body per se in one go. But obviously, we just went by the hospital protocol.
Oh, you have phenomenal liberties. For me to do all of those things, I need about 10 people giving me permission to do this or do that or do the other. And so, yes, but this is just fantastically well done and very well worked up. Perfect.
My main thing why I wanted to, reach out to the audience was that we don't realize what prednisolone over 5 milligram can do on a long-term basis. And we deem 5 milligram of prednisolone as a very benign, innocent kind of dose, if you look at the whole part of it. And I was in India recently, and one of my friend, an ophthalmologist, for a viral infection, he was given a high dose of dexamethasone. I know, these things still happen in certain parts, certain regions, and steroids are probably, misused, especially by different practitioners, not, but I witnessed it this time in August. One of my own classmates, practicing ophthalmologist, being given steroid for a viral infection, ending up with a secondary bacterial infection.
You're absolutely right. When challenged, they will tell you that they use these high doses because that's how they can stop the inflammatory process. But to me, it doesn't make any sense.
There is no bacteria or virus which can be killed. Yeah.
Exactly. So you're absolutely right.
I think, unfortunately, in COVID time, we got sort of a license to use high dose steroids, and now post COVID, we are facing all those side effects and sequelae of even high dose. I think overall the prevalence and new onset diabetes since post COVID has suddenly gone up because patients were put on very high doses, because that time there was hardly any rescue medicine, and that discovery trial, which almost gave a license to use high dose steroids, many patients were given rampant steroid doses, 16 milligram twice daily of methylprednisolone, which is very, very high dose, and it was continued for 4 weeks, 6 weeks, and 8 weeks to prevent that acute inflammatory process and those lung manifestations of COVID and those excursions. So that has led to very high prevalence of hyperglycemia those times. And that is why, if you remember, if you have heard those Indian news and certain data published from India, that mucormycosis suddenly went up, and it was being correlated to COVID, why there is a black fungus suddenly coming up, and it was all because of very high doses of rampant doses of irrational use of steroid, I think. So it's a great
anecdotal
learning,
experience.
I think. Yeah,
I've got anecdotal experience of my own relative taking, my own mom's sister taking a high dose of steroid, and then her circadian rhythm changing. She wasn't normal. Kind of people under recognize what the steroids do. So it was a very simple presentation. I just wanted audience to know 3 things. the physiological replacement dose for cortisol, 5 milligram of prednisolone. And yes, if you're using more than that for more than few weeks, think about the bone protection, GI protection, think about glycemic control.
You have to have a reason to use more than 5 milligram prednisolone. Very rightly put up. I think in a very simple way, you have conveyed message, which is very, very loud. Thanks a lot, Dr. Kalhan, for a wonderful session. Really. So we go to the next session, that is by Dr. Rakesh Sai. Dr. Saha is a very, very close friend. We have been working together in RSSDI for almost 2 decades now. Currently serving as Professor and Head Department of Endocrinology, Osmania Medical College and Hospital, Hyderabad. He is President-elect Research Society for Study of Diabetes in India, currently 22-23, and immediate past President, Endocrine Society of India, Vice President, South Asian Federation of Endocrine Societies, and section editor tropical endocrinology. He is also on editorial board of IGM and has numerous awards to his credit, almost more than 250 publication in PubMed index journals, and has been awarded best teacher in medicine award from government of Telangana, and is currently also scientific chair for upcoming RSSDA national conference at Mumbai, that is RSSDA 23. So it will be pleasure to listen Dr. Rakesh Sai, who is going to talk about microbiomes, its role in diabetes. Over to you, Dr. Sahai.
Thank you, sir. Thank you for the kind words of introduction, and thanks for inviting me to be here in this very interesting and important program that you're organizing. I will share my screen and go on to discuss about how gut microbiota also could play a role in diabetes, because we know that we are going through this pandemic of obesity, while we are speaking about the COVID pandemic and all that, but we are in this pandemic of diabetes. Obesity is increasing worldwide. In our part of the world also, it is about almost 30% of people are obese. And we see that and obesity is the driving factor for the development of diabetes. And together, we look at diabetes, that's a huge burden. And if you look at it from a different angle, while we always look at the environmental factors, there is another important factor that has been recognized. We speak about the ominous octet, and then when we are now extending that and understanding what are the other mechanisms that could be playing a role in the development of obesity and diabetes, probably gut microbiota become a very important factor. And what we see is that the human body itself is a home to complex communities of microorganisms, and there's a huge number of microorganisms. They're more than the number of human cells that we have, and majority of the microbiota are present in the GI tract, and this abundance increases when you go on from the stomach to the colon. And you can, to make it very simple, it's a very complex topic, but I'll try to speak in a few simple terms so that there can be a carry home message for all the delegates who are attending. So if we look at bacteria, we can divide them into 4 major groups, and this constitutes almost 95% of the total microbiota are belonging to these 4 groups. They are firmicutes, the bacteroids, Acetonobacter, and the proteobacteria. And if you look at so having a diversity of these bacteria is very important. If you have a propensity of bacteria that are harmful, then they can lead to a series of problems that I'll be showing you how that happens. But having a wide sort of diversity of this bacteria makes the person more likely to be healthy. So if you look at the microbiota, this probably is a neglected endocrine organ itself, the gut microbiota. They produce numerous chemicals of hormonal nature that are released into the bloodstream and act at distal sites. So if you look at the various gut microbiota, the various factors that are hormonal factors, we could say, that are produced by the gut microbiota, we have the short chain fatty acids, which are energy sources. They affect the host metabolism, and they also serve as signaling molecules. Then you have a variety of neurotransmitters which are produced by the gut microbiota, and there are several precursors to neuroactive compounds which are being produced. The bile acids are being metabolized. The bile acids, the secondary bile acids, which have an important role to play in antimicrobial and host metabolism, also are regulated by the gut microbiota. And then choline metabolites again are which have an important role in lipid metabolism, also are influenced by the gut microbiota, or are produced by the gut microbiota. The hormones like cortisol, which regulates the stress response. We just heard about the various effects of cortisol, and that again is to a large extent regulated by the gut microbiota, and and other GI hormones like ghrelin, leptin, and GLP-1, PYY. All of them have been produced by the gut microbiota. So because of these endocrine outputs from the gut microbiota, they have a significant effect on regulating the host metabolism. They have effects on the stress and HP axis. They alter the brain and behavioral mechanisms. They have effects on the immune system, cardiovascular system, and also on the enteric nervous system, that is the gastrointestinal tract. And as you can see, if we look at some of the effects of the short chain fatty acids, the short chain fatty acids have effects on host energy metabolism in the peripheral tissues. They are produced from the dietary fiber, which is acted upon by the gut microbiota to produce short chain fatty acids, and these have effects on these GPR receptors, different GPR receptors, which are regulating the insulin secretion, the adiposity, leptin secretion, and also the GPR41 receptor, which has effects on of increasing norepinephrine and increasing the intestinal sugar metabolism via the intestinal brain axis, is all once again influenced by the short chain fatty acids. So as you can see, these short chain fatty acids, which are produced by the fermentation of the gut microbiota, the effects of the gut microbiota on the dietary fiber leads to the production of these short chain fatty acids, which have a host of effects on various receptors regulating the not only the gut motility, the insulin secretion, the adiposity, the blood pressure, and thereby having these host of effects that we have seen. The microbial effects, this also affects the inflammatory signaling also. And as you can see, the T regulatory cells mediated immunity is regulated by the secreted IgAs, and again, which is again influenced by the gut microbiota. And not only by the short chain fatty acids, but also by the polysaccharide A and the quorum sensing molecules, which are again influenced with gut microbiota. They have a variety of effects on the inflammatory signaling, and thereby affect the overall inflammatory sort of signaling across the body. And if you look at what happens when the good bacteria, like if you look at the Bifidobacterium longum, which has all the beneficial effects, there are some of these which have the bad bacteria. So in simple terms, you could say that whenever there's gut dysbiosis, we are saying that we are seeing a reduction in the good bacteria and an increase in the bad bacteria. So this in turn leads to a reduction in the production of short chain fatty acids, and insufficient or inadequate microbiota leads to dysregulation of the immune effects, accounting for changes in the systemic non-intestinal allergic conditions also. So these are all the effects that we've seen with the dysbiosis, gut dysbiosis. It also leads to elevation in circulating and tissue microbe associated molecular patterns such as lipopolysaccharides and peptidoglycans, and these again have effects on of increasing inflammation, increasing insulin resistance. So what we are seeing is that the gut dysbiosis has a significant effect on the insulin resistance, has a significant effect on inflammation, and thereby has significant effects of driving the epidemic of obesity and diabetes, and the gut microbiome homeostasis is affected by to a large extent by the dietary practices and several other factors that we have seen. So studies have demonstrated that the gut metagenomic markers are able to differentiate between the different types of, different, we could say, the phenotypes of type 2 diabetes also. They may be useful in making this sort of classification of type 2 diabetes also. So recent metagenome-wide association studies have shown that patients with type 2 diabetes are characterized by a moderate degree of gut microbial dysbiosis, decrease in the abundance of some universal butyrate-producing bacteria, and increase in various opportunistic pathogens. Also observed changes in the proportion and diversity of gut microbiota, even in pre-diabetes also. So the progression from obesity to pre-diabetes to diabetes is influenced to a large extent by the gut dysbiosis. And so it suffices to say that the development of obesity, insulin resistance, type 2 diabetes, and metabolic syndrome in general are the consequences of complex multi-directional interaction between the host genetics, the environment, diet, and the gut microbiota. So this is clearly shown from various metagenome-wide association studies in patients with type 2 diabetes, and that the gut dysbiosis, bacterial dysbiosis, has a significant effect on the development of not only type 2 diabetes, which you've just looked at, but there could be triggering factors which could lead to genetically predisposed individuals having a greater degree of inflammation, increased intestinal permeability, promoting inflammation, promoting insulitis, beta cell apoptosis, and thereby leading to increased development of type 1 diabetes also. So as we can see, this slide summarizes the various effects that we see. So this highlights the fact that not only obesity and diabetes, but it has a significant impact on the development of cardiovascular disease, atherosclerosis, neurological conditions like Parkinson's, Alzheimer's, multiple sclerosis, depression, anxiety, inflammatory bowel disease, irritable bowel syndrome, ulcerative colitis. And recently we have got more some evidence on the effect of gut dysbiosis on development of sarcopenia, rheumatoid arthritis, and also in endocrine disorders like hypothyroidism. So these are some of the data that has come out from various studies now. And this slide actually summarizes how the dysbiosis can lead to the various problems that we are speaking of. When you're speaking of obesity, we're saying that dysbiosis prohibits the AMP kinase in hepatic cells, which leads to accumulation of fatty acids in the tissues. Similarly, in PCOS also, the dysbiosis increases the androgen levels in the ovaries that results in inflammation that may induce follicular growth and PCOS development. So as we can see, by different mechanisms, the gut dysbiosis is contributing to the development of various endocrine problems. And as we've already discussed in detail about how it affects the development of type 2 diabetes. Now, so we can say that obesity is significantly influenced by gut microbial dysbiosis, where the gut microbiota, which are supposed to restrain the adenosine monophosphate kinase, AMP kinase activity in the liver cells, that finally causes extra accumulation of fatty acids in the hepatic and muscular tissues and contributes to the development of obesity. And this in turn leads to reduction in the GLP-1 levels, which is, we all know that GLP is an important modulator of the uptake of energy into the intestines, which results in insulin resistance. And it has been shown in various studies that there is increased abundance of the bacteria, the microbiota like bacteroids. They are increased while the favorable ones are decreased. There are two major. So we need to look at how we could target this gut microbial dysbiosis and favorably affect the outcomes. In terms of the diabetes, obesity, and there are potential therapeutic targets or strategies that are available: the prebiotics, the probiotics, as you can see, postbiotics, and then the other mechanisms like adaptive transport of T helper cells, anti-inflammatory agents also have an effect on the also could be used for targeting the gut microbiota. Immunization with high-fat diet associated ileum microbial extracts can also be used. So these are various potential strategies that have been studied. So I'll quickly focus on, I will not focus too much on the the pro and prebiotics, but I'll focus on some of the anti-diabetic drugs which can influence the gut microbiota. So metformin increases the abundance of Akkermansia, a mucus degrading gram-negative bacteria in the gut, which is associated with the restoration of the reduced regulatory Treg cells and amelioration of low-grade tissue inflammation in the adipose tissue of obese animals. So it has some effect on the, apart from all the known effects that we have of metformin, we also have an effect on the gut microbiota also. It increases the lifespan of Caniroids elegans by metformin has also been attributed to changes in the intestinal microbiota. So thereby, this can probably explain some of the newer understanding that we are having about the effects of metformin. So metformin treatment improves the gut microbial diversity by enhancing the short chain fatty acid production, promoting the activity of the endocrine cells, regulating the bile acid turnover, and reducing the endotoxemia. If you look at acarbose, this is again an interesting molecule, which we are learning more and more about this molecule, which has been there for a lot of time. I mean, we've been using it for a lot of time for mainly its effects on the GI tract, and where we were looking at only the delay in the breakdown of disaccharides to monosaccharides. But what we see is that by increasing the transit time and delaying the breakdown of the oligosaccharides and disaccharides, there is increased production of, I mean, there's increased production of short chain fatty acids and hydrogen gas, which is understood to be a side effect of metformin of acarbose, but that itself is found to have certain benefits, that it increases the short chain fatty acid production, which are as we've seen, have many beneficial effects, and thereby they lead to, they mediate the suppression of pro-inflammatory cytokines like interleukin-1 beta, TNF alpha, and IL-6 in the inflammatory tissues. And this has been attributed to many of the cardiovascular benefits of acarbose. So acarbose is structurally similar to a tetrasaccharide, and it because of these mechanisms, it has these favorable effects on the gut microbiota. And so this has been studied in 1 or 2 studies. I'll just quickly quote one study which looked at 95 type 2 diabetic patients who were randomly assigned to acarbose, and they divided another group which was received similar treatment to group A but without acarbose. And when they looked at the inflammatory markers, they found that the acarbose treated group had much lower levels of these markers. And similarly, there were other studies which looked at the effect of acarbose on the gut microbiota. Again, they showed significantly increased levels of Bifidobacterium longum and decreased levels of Enterococcus faecalis in both the groups after treatment for 4 weeks. Those were treated with acarbose. So acarbose treatment led to significantly increase in the pro-inflammatory, a significant decrease in the pro-inflammatory cytokines, and increase in the significant decrease in the pro-inflammatory cytokines and increase in the anti-inflammatory cytokines. So this thereby is one of the benefits that we have seen with acarbose. There are similar small studies which have looked at these effects, and they have shown that there is a higher abundance of some of the good genera of the microbiota, and lower abundance of the 6 genera which are found to have the harmful effects. So through all these small studies, we've looked at the favorable effect that acarbose has on the gut microbiota, and promoting the favorable growth of the favorable microbiota and the anti-inflammatory effects that it produces. So these have been extrapolated to be the reasons for some of the cardiovascular benefits that we have seen with acarbose. When you look at the effect of OADs on other OADs, they have not been studied extensively. Apart from metformin and acarbose, we don't have much data on the other OADs, but this is something which is interesting. And as I've just mentioned, that because of these beneficial effects that we have seen with on the gut microbiota and the anti-inflammatory effects that are produced, this is postulated to have several cardiovascular beneficial effects by modulating the gut microbiota. So this is a recent real-world evidence also when they looked at the benefit of acarbose versus SUs, in which we are all aware of, and this could also be to some extent be mediated by the effect of acarbose on the gut microbiota. Now I will just mention a little about this fecal microbial transplantation, which refers to altering the host gut microbiome in order to provide a therapeutic effect. It involves the introduction of microbiota from a healthy donor species to the morbid individual's GI tree, and has been used in treatment of metabolic syndrome and diabetes. Various methods are employed, like you could use the upper GI route or the lower GI route also could be used. This has several challenges, although some beneficial effects have been shown, and needs to be sort of refined further. But I would like to just mention that there's something else called as a bacterial consortium therapy, where which involves the use of defined drug composition produced from clonally isolated bacteria that can trigger targeted immune responses, and specific intestinal ecosystem modulation could be performed with this bacterial consortium therapy. And a recent study has showed complete recovery in effects comparable to those with fecal microbial transplantation with bacterial consortium therapy as a substitute. So this is something which may be more acceptable to people rather than fecal microbial transplantation. So with this, I'll try to conclude by saying that intestinal microbiota have been identified to have to be a fascinating new endocrine organ, and they affect many biological systems, including the immune system and metabolic functions. The gut microbiota has a significant role to play in the development of diabetes and the various complications of diabetes itself. Modulation of the gut microbiota composition and function has the capacity to has a great potential to alter the host metabolic profile in a desired favorable direction. Favorable effects on the microbiome in diabetic patients have been shown with agents like acarbose and metformin, and we need to have further studies to look at this and how we could favorably alter this endocrine microbiome crosstalk to favorably impact the health of people with diabetes. With that, I'll conclude. Thank you all for the patient hearing.
Yeah, thanks a lot for a very wonderful session on microbiomes. I think it's a very, very complex topic, but still you are trying to put it in a very simple way, especially the role of fecal microbial transplant, FMT, or what you in the end said, a consortium of antimicrobial therapy to change the metabolic dysfunction and to earlier we know that it was primarily responsible for metabolic syndrome and type 2 diabetes, but certain evidences which you have shown that even in type 1 there is a role of altered microbiomes which predispose to onset of type 1 diabetes. So I think it was wonderful. I don't think we have any question in the chat box, but we'll request you to stay back because we have another very important session by Professor Adi Mehta, and towards the end we might have certain comments from you and Professor Adi. May I have his introductory slide? Professor Adi Mehta is faculty attending staff endocrine and metabolism Institute at Cleveland Clinic since 1993, associate professor, Department of Endocrinology and Internal Medicine, University of Manitoba at Manitoba, Canada, and he is also member of American Association of Clinical Endocrinologists, the Endocrine Society, and American Diabetes Association. I think this slide itself talks about the humbleness of such a senior endocrinologist, a endocrinologist par excellence. I think we have known Dr. Mehta over the last 10 years through our Cleveland certification program organized by Dr. Makkad. One of the most sought after international endocrinologists, I'll say. Very straightforward, Dr. Adi Mehta. Over to you, sir.
Thank you very much for this invitation. Thank you very much for your very kind introduction. I'm sure my mother would not recognize me. Having said that, the next step is the biggest step. That's the most difficult step for me, is to try and get this thing to share my screen. So I'm hoping that this works.
Many times you have been facing that problem.
Yes, absolutely.
Last year also it happened.
Absolutely. I'm well known for being totally electronic inept.
No, sir.
Now, I don't know whether you can see any of my slides.
Slide from beginning. Extreme upper ends from beginning slideshow. From beginning. Extreme left, sir. Extreme left. Upside panel, sir.
You just need to click on from beginning. Yeah, this is perfect. And you just need to go to the slideshow.
Slideshow. At the top of slide, there is a slide.
Yeah, perfect.
Perfect, sir.
Okay, so thank you very much, and sorry for the hassles in introducing myself. Basically, I'm going to be talking about euglycemic DKA. This is probably the hottest thing that's come out since SGLT2 therapy has been initiated. And the big question always is, if you have an episode, does that mean you can't use an SGLT2? And I'll come back to answering that question towards the end of this program. So, acidosis and increased plasma ketones. I think everyone knows that. And I need to preface this comment by saying one thing, please. What I'm going to say is known by everyone, but there are nuances that we need to stress. So therefore, I may be going to data you already know, but I'm going to stress the nuances of how the euglycemic DKA changes. Essentially, euglycemic DKA is without the hyperglycemia. Your serum glucose is usually less than 200 to 250. It can occur in type 1 diabetes and now tends to also occur in type 2 diabetes. It's almost always associated with partial treatment of diabetes, meaning there's some degree of insulin insufficiency. There's a significant degree of carbohydrate or nutrient deficiency, severe keto diets, alcohol intake, which also limits the same thing, and in any effect of inhibition of gluconeogenesis. So the sodium glucose transporter, SGLT2 therapy, has been found to be highly associated with the development, or with the possible development of DKA. The earliest report was way before any SGLT2 was even a dreamer. And that was back in 1973, and it was reported, and the risk factors were exactly as we've said: fasting, keto diet, surgery, and pregnancy. Approximately 2.6, about 3% of DKA admissions are euglycemic. Now, that's something we don't always pay attention to. With the advent of the SGLT2 inhibitors, the rates have ranged from about 0.2 to 0.8 events per 1,000 patient years in patients with type 2 diabetes, which is DKA is relatively rare in type 2 diabetes. And the estimation is that there's a 7-fold increase in type 2 diabetes patients for DKA with the SGLT2, and the overall incidence is about 0.1%. They're not approved for use of type 1 diabetes. I think everyone knows that, and that I'm not going to belabor that point. However, there are ways you can go beyond the license. I don't know that I want to go into this here. Patients presenting with DKA SGLT2 with type 1 diabetes was almost up to about 10%, but euglycemia was not always present. The common factor in this was that because they used the SGLT2 and the sugar started to fall, they started cutting back the insulin. While it is very appropriate to cut back the prandial, once you start cutting back basal and you get basal below a certain level, you are set for developing a euglycemic DKA state. I'm going to talk about how ketone bodies are synthesized and gotten rid of. Ketone bodies are made in the liver. It is by fatty acid oxidation going to the acetyl-CoA and the 3-HMG system to give you 3-beta-hydroxybutyrate. These 3-hydroxybutyrate something that we don't always pay attention to, is actually a very powerful nutrient for muscles to be used. So in muscles, it can be used to generate energy. And so ketolysis occurs, ketogenesis occurs in the liver, ketolysis occurs in extrahepatic tissues, especially the muscle. Liver cannot utilize ketone bodies. It cannot break it down. Extrahepatic tissue cannot form ketone bodies. So it's very clearly defined areas. Red blood cells cannot utilize ketone bodies due to the absence of mitochondria, and acetone does not undergo ketolysis, but it's because it is excreted to the lungs. These are absolute facts about the ketone bodies. When the rate of formation of ketone bodies in the liver is greater than what the extrahepatic tissue can utilize, you get ketonemia and ketonuria. Ketone bodies are relatively strong acids, and therefore it is significant that you get an acidosis associated with high ketones. So in patients with diabetes, the events that lead to ketoacidosis are relative or absolute. In the case of the SGLT2, it's relative. In the case of type 1 diabetes, it's an absolute deficiency of insulin. Thereby you mobilize free fatty acids. This increased metabolism of free fatty acids in the liver leads to the accelerated production of ketones. When you look at SGLT2s and postprandial ketonemia, what you see here is baseline, acute dosing, and chronic dosing. Notice that with chronic dosing, there is almost an ambient level of ketonemia. Remember that you define ketoacidosis as a presence of more than 0.3 is supposed to be ketones. It's supposed to be abnormal. And here you're using between 0.3 and 0.5 in a normal individual, just because they're on SGLT2 inhibitors. Okay. When you look at what happens to renal handling, renal is supposed to excrete ketones, but in amount of reabsorption that occurs when you get high ketones starts to become a major factor, as you can see with chronic treatments with SGLT2. So there is a good part about ketone bodies. Everyone knows that ketones are used by cells preferentially to free fatty acids. So in terms of pecking order, yes, glucose is the major driver, but then an intermediate metabolism is run by ketones rather than free fatty acids. So in effect, it is a very important source of fuel if it is used in the presence of insulin and it is used within the realms of normality. In euglycemic DKA, what happens is the SGLT2 inhibitor causes glycosuria, causes natriuresis, and increases ketone body absorption. Perfect. On the other hand, it specifically increases glucagon, and thereby the glucagon-insulin ratio is in favor of glucagon. If for any reason your insulin secretion goes below a certain level, now you've got an excess amount of free fatty acids being released, and you're going to get ketogenesis within the liver. This ketogenesis, together with the increased absorption of ketones from the liver, from the kidney, is going to cause an increase in plasma ketone bodies, and you've got a diabetic ketoacidosis. Euglycemic, because you're losing glucose in the urine, so therefore you not have the drive to keep the glucose in the blood. If you look at the differences between DKA and EDKA, the most important difference is that while there's a significant deficiency of insulin in DKA, the insulin in the EDKA is much less, but the glucagon-insulin ratio is markedly in favor of glucagon. And also in SGLT2, glucose utilization is preserved to a certain extent. You've got glycosuria, you've got ketogenesis, and that together is going to give you the euglycemic diabetic ketoacidosis. This is an attempt to look at the effect of insulin, and look, the lower the insulin at baseline, the higher the amount of beta-hydroxybutyrate. So therefore, you have to keep that in mind when you think about using SGLT2 in individuals. Is there a way to predict whether this person has a low insulin or has adequate insulin? We'll talk about that in a minute. Risk factors for identifying people who might have problems with SGLT2. Obviously, if they've had prior DKA. I don't want to press too much on that. But if the hemoglobin A1C is very high, that means under poor control. The next thing you look at is a bicarbonate. If the bicarbonate is already around 20, 21, that tells you that they are already running a certain amount of insulin deficiency. They've got a certain amount of ketosis. That's why their bicarbonate is low. That's not a candidate for an SGLT2. If the bicarbonate is already low, you don't start an SGLT2. If the creatinine is very low, that means the muscle mass is very low. Therefore, they're not going to be able to utilize ketones appropriately. Not a good place to start SGLT2. Creatinine is high. Now you've got the acidosis of CKD. Again, you don't want to start there. The others are self-explanatory. The acute predisposing factors for an SGLT2 causing DKA are fasting state, a perioperative state. You therefore tell people to stop the SGLT2 2 or 3 days before, and we'll stress that why again. Obviously, if you're going through a bariatric operation or you're going to be prolonged NPO, you don't want to be on an SGLT2. Ketogenic diets, again, not anorexia, alcohol intoxication. Those are all the general problems that we forget about when we think about patients who might come in with an SGLT2 related DKA. Gastroparesis, glycogen storage diseases, yes, they occur, but they are relatively less frequent in clinical practice. If you want to remember in mnemonic, remember derails. D for diarrhea, E for emesis, E for exercise. Those are all causes of intravascular depletion, volume depletion states. And ketoacidosis prone states, reduced oral intake, ketogenic diets, your NPO, alcohol, inpatient hospitalization, which leads to the same thing. Underlying LADA, where there's already a problem with insulin production, and surgery. So I think if you remember the mnemonic derails, you'll think about all the factors that could potentially predispose to the euglycemic DKA. Now, I'm going to talk about the management of DKA in the next few minutes, and I'm hoping it's going to take too long. Number one, blood gases. You don't have to have an arterial blood gas. In fact, venous blood gases are very good. And the last bottom of the slide tells you that venous blood gases are about 97.8% sensitive and 100% specific for the diagnosis of DKA. You don't have to have an arterial blood gas. Why are you worrying about arterial blood gas? It's painful and it can be dangerous, especially in type 2 diabetes with vascular disease. You'll get into problems. I don't know how many of you, before you do an arterial blood gas, actually check the radial pulse, or if you put pressure on the radial pulse to see if the hand blanches. No one does that, but it's something we need to keep in mind in this group. Not in type 1s, because they're usually not that badly vascularly. In the management of UDKA, what is the important differences from generalized DKA? Well, obviously, you want to start with fluids, but you've got a patient who's already coming in with less than 250 glucose. You want to start a fluid with glucose for two reasons. Number one, you're going to give insulin. But number two, more importantly, you want to stop the ketogenic process. You want to give him glucose so that he stops making ketones. So it's crucial to remember difference from DKA that you want to think about using glucose in the fluid. Obviously, you want to give insulin, and we'll talk about insulin in a minute. So what sort of fluids are we talking about? Well, normal saline is probably the best fluid we can think about. But I think it's important to remember that there are electrolyte solutions that are a composite of plasma volume. And when you use those, they tend to give you a much better turnout in terms of hypochloremic acidosis as we treat the diabetic ketoacidosis. Those are expensive fluids. I don't want to push on them. So normal saline remains the easiest, cheapest fluid to use. And you want to use approximately 15 to 20 mils per kilogram in the first hour, and then sort of maintain euvolemia. Remember that you want glucose because you will be giving insulin. We talked about the fact balanced electrolyte solution versus normal saline. I just want to stress one fact. Ringer's lactate has no place in the treatment of DKA, whether it's UDKA or it is not, has shown no benefit whatsoever, and it probably takes a longer time to show any improvement. You all know that if you're hyponatremic, you use normal saline. If you become normonatremic or hyponatremic, you use half normal saline. Potassium has always been a big issue, and potassium remains an issue with euglycemic DKA with SGLT2. I think it's very important to get into the habit of checking the potassium before you start insulin therapy. If the potassium is already low, the IV fluid should contain at least 10 or 20 milliequivalents of potassium. Otherwise, the giving of insulin will drive the potassium into the cells and give you a problem. So I think it's very important to always remember fluids first, then potassium if it's added, and then the insulin. Now, it is important to remember that SGLT2 therapy actually causes a slight rise in serum potassium levels, and this might be compounded by the presence of CKD, so you're not as much at risk with SGLT2 related. How about insulin therapies? Well, there's always this controversy between low-dose insulin therapy by various routes. Yes, everyone used to say intravenous infusion of insulin is superior to subcutaneous route, but in fact, in the early 2000s, Guillermo has clearly shown that subcutaneous insulin aspart used every 1 to 2 hours. Remember, low doses of these analogs do not last more than 2 or 3.5 hours. It's a very safe and alternative way, but most importantly, it stops you from having to be admitted to the ICU. That becomes important, and I'll mention it again when we talk about it. So I think it's very important to understand that you can use this and it can work. Does it have to be regular insulin versus Lispro? Lispro, you do frequent monitoring and frequent injections. Regular insulin, you can extend it out a little bit. What about the initial bolus that you get to give, that everyone sort of motherhood says you give in the treatment of diabetic acidosis? In fact, it's been shown that there is no difference between giving a bolus or not giving a bolus. And in fact, giving the bolus increases your chance of hypoglycemia. What about bicarbonate therapy? Now, this is very important UDKA. Reason why it is very important UDKA is because they come in with a low bicarb, the sugars are low, you treat them and the ketone and the anion gap closes, but the bicarbonate doesn't come up. And that's very bothersome to people. So they start using bicarbonate therapy. Bicarbonate therapy has shown no benefit. Again, I will come back to why there's a delay in bicarbonate therapy, bicarbonate recovery with SGLT-related UDKA. If you look at controversies with phosphate therapy, phosphate has been pretty well ruled out as a necessity for DKA. But in patients with SGLT2-related DKA, please remember that SGLT2s increase serum phosphorus, increase the PTH, and so therefore, there is, in fact, really no absolute reason to use phosphate. And phosphate has never really been shown to have that much benefit, even in DKA. Now, this is the most important slide of this presentation because it tells you the biggest difference between DKA and UDKA. The biggest difference is that the half-life of these agents is about 12 to 17 hours. Therefore, if you come in with a euglycemic DKA on SGLT2s, do not expect the diabetic ketoacidosis to be reversed in 24 hours. Yes, you got numbers that says you reversed it, but because of the ongoing effect of the drug, you're going to go back into DKA. You have to prolong the therapy. Because you're prolonging the therapy, you want to take measures to protect against having long-term ICUs. That's why the subcutaneous insulin. That's why the concept of giving glucose with the fluid so as to stop the ketogenesis early. I think it's very important that these are nuances we don't pay attention to in regular DKA, but in a euglycemic DKA, it's very important to make sure that glucose is in the IV, that you're watching the potassium, and that in fact, the insulin therapy is protracted and don't expect an immediate response like we do with regular DKAs. Remember that the elimination is most of the time in the kidney. So there's already a problem with CKD, that elimination time is going to be further increased. So patient education and precautions. Obviously, if you have patients, they should recognize what acidosis smells like: thirst, nausea, vomiting, abdominal pain. For high-risk patients, they might want to actually measure the ketones in the urine. You want to make precautions to lower DKA risk. Don't decrease the insulin too much, especially the basal insulin, because the basal insulin allows the glucagon-insulin ratio to be in favor of more of insulin and glucagon. Stop the idea of ketogenic diets and highly restrictive diets. If you're going to go on an NPO, you have to stop the SGLT2 at least a day or two before to cover the half-life. Obviously, no alcohol. And again, you want to stop it about 2 days before surgery. Patient selection considerations. If you have a leaner patient with type 2 diabetes, remember, he might have significant limitation beta cell capacity. Think twice. Higher hemoglobin A1C, and I've already told you about that. Clinical considerations. They should not be excessively ketogenic or fasting diets. Infection can oppose the action of insulin, so we worry about them, and we talk about the half-life. Remember the prolonged recovery. So, with regards to the question at hand, if we understand the etiopathophysiciology of UDKA with SGLT2 inhibitors, we can take precautions to not allow it to happen. So if you're worried about something, you ensure the presence of background insulin before you restart the SGLT2. Either use a basal insulin, put him on a GLP-1 receptor agonist, which induces endogenous insulin, or even a DPP-4 inhibitor, or people are going to be shocked, low-dose SFU. Again, you want to allow there to be a presence of insulin so that the insulin-glucagon ratio doesn't go too much in favor of glucagon. If you ensure that, there is really a very reconcilable divorce between using DKA after using SGLT2s after DKA. So in my opinion, if you take the precautions, you choose your patients right, and you teach your patients right, there is no reason to say, well, now that you've had one episode of UDKA, you cannot ever go on an SGLT2. There are far too many pleiotropic effects that are beneficial in heart failure, in kidney, that we should not take away this major armamentarium to our drugs just because of something that we maybe can be preventable. I'd like to stop there and take whatever questions you got. Thank you very much for your attention.
Thank you, sir, for an awesome lecture. Wonderful oration on a topic which is we face day to day. Ever since we have been using SGLT2 inhibitors for last 7 years or 8 years, I think this is a very, very common problem, and you have tried to sort out almost all answers that probably 1 or 2 episodes of UDK will not preclude the use of SGLT2. It's not a permanent divorce. Only thing is you need to follow do's and don'ts, which have been taught right in the beginning before SGLT needs to be started. And I think the benefits from SGLT2 still can be harvested if we use them in the right patient. So the right choice of the patient, the right situation, patient needs to be very well hydrated, patient needs to be on carb diet, should not be starving, should not be vomiting, should not be having excessive diarrhea, should not be in a surgical or immediate before surgical situation. And of course, any sepsis or urosepsis, myocardial infarction, that is the time you should stop SGLT2. But these days now with the evidence coming, I think that DARE-19 trial on dapagliflozin almost started that even in an acute situation, you could use SGLT2 as early as maybe moment patient is hemodynamically stable in 72 hours, maybe post-MI, post-sepsis or post any surgical infection, so as to get the benefits which are going to be there with SGLT2 inhibitor. Of course, you very well alluded to that patient needs to be hydrated, and we must ensure that there is enough beta cell reserve, at least an insulinization, enough levels which will not put patient in repeated episodes of UDK. I'd like to invite comments from Dr. Rakesh Sai, who is a lead endocrinologist from this country, to share his experience and say certain words of wisdom for all the delegates, those who are still logged in till late.
Yeah, I think that was a brilliant presentation by Professor Adi Mohita, where he spoke about the management of euglycemic DKA versus the routine DKA that we see. And I think the most important point, as Dr. Chawla has also summarized, is that we need to just see that we are hydrating the patients well and giving adequate insulin. As long as they are having adequate insulin on board, I think the SGLT2 inhibitors would not be a problem, and they can be used again in the appropriate situation to get the benefits that we know that they provide.
I think wonderful, sir. It was a brilliant oration. And most important thing is that we wake you up so early in the morning to get your lecture towards the end of the. And I think delegates, those who are logged in till 9 o'clock, it is worth, because we had 3 wonderful lectures from Dr. Sahai, Dr. Atul Kallan, and from Dr. Adi Mehta towards the end. And what I said, that your slide of introduction talks about your personality, your modesty, and your that keenness to teach the audience. Every time we meet you in Delhi in Cleveland program, we keep learning every time from you, and your that keenness to teach the delegates is extremely appreciable. So
thank you very much. You humble me. It's been very good. Thank you. And I really thank you for the opportunity. So appreciate that.
Thanks a lot. So it has been a wonderful session. Towards the end, I think all the delegates, those who are still logged in till late, must have benefited entirely from the discussion by all 3 the top endocrinologists. So with that remarks, we will like to close the session today. Tomorrow again, we are going to start at 1:30, and we will finish tomorrow again at 8:45 or 9 o'clock by a wonderful oration, I can promise, by Dr. Dandona. So I think that is one reason that why we start towards afternoon, and we need to continue program till 9 o'clock, because every time we want you, Dr. Devjit, and Dr. Dandona to be part of our program. And obviously, for getting you in our program, we can't ask you to join at 6 p.m. So I think every delegate must be grateful, and a lot of learning and insight. At least I am really enlightened with wonderful oration by all 3 of you. So once again, thanks a lot.
Thank you,
Thanks
sir.
a lot to all the audience delegates, those who are still logged in since 1:30 p.m. It has been almost 7.5 hours, but I think it was worth. And tomorrow, once again, we promise that we will have equally good and wonderful deliberation by many national and international faculties. So good night, everyone. And once again, our gratitude to all of you. Thank you
very much.
Stay safe and good
Thank you
night.
for the invitation.
Thank
And
you.
thank you.
Good night, sir. Good night.
Yeah.
Thank you, Adi, sir.
Thank you.
Once again. Good night, sir.
Thank you.
Recording stopped.